Okay, good evening, everybody, and welcome to this 18th edition of IOACON 2020 Bounce Back. And I'll hand it over to Dr. Ajit Shinde, who is the organizing chairman of IOACON 2020. Over to you, sir, to initiate the meeting.
Good evening, dear friends. Greetings from Maharashtra. I, Dr. Ajit Shinde, chairman of IOACON 2020 Organizing Committee and president of Maharashtra Orthopaedic Association, welcome you all to the 18th episode of Bounce Back series. Today we are discussing malunion and non-union of proximal tibia fractures. Indeed, one of the difficult scenario to manage. Malunion are commonly encountered in complex fracture involving both lateral and medial condyles like Shaskar type 5 or 6. What I have seen is mainly the compound injuries land up in such a type of complication that is infected non-union with or without active infection. So, while managing such cases, in addition to achieve goal of acceptable alignment and union, one must take care of the knee joint to have optimum outcome. So, to discuss this interesting topic, we have eminent faculty including Dr. Tanna Sir, Dr. Kishan Kretak, Dr. Gade Gune, Dr. Maheshwari, Dr. Chaudhary, Dr. Jethwa, Dr. Gavaskar, Dr. Pandya, and Dr. Umbre. My friend, Dr. Chandak is going to moderate the session. We have discussed variety of topics on this platform, and we have been blessed to have wonderful faculties till date. I am sure these faculties will update us regarding all the aspects of this challenging issue. Without wasting much time, we shall begin. I request Dr. Chanda to proceed further. Thank you. Thank you very much.
Thank you, sir, for those words. Today we are fortunate to have a galaxy of faculty with us. So we welcome you to this webinar. We offer our floral welcome to Professor Ajit Shinde, Ashok Sham, Neeraj Bijlani, who are coordinating and giving us a flawless audiovisual.
So we offer make it full screen, sir.
We offer our floral welcome to Professor Didi Tanna, who will be joining us shortly, Professor Christian Kretek, who has joined from Germany, Professor Jawahar Jethwa, Dr. Jiten Maheshwari, Dr. Rajiv Rai Chaudhary, Dr. Vasudev Gadegune, Dr. Jignesh Pandya, Dr. Ashok Gavaskar, and my friend Dr. Alok Umbre. Welcome all the faculty members. We are really fortunate today that we have Professor Christian Kretek with us, who will be delivering his keynote address at around 5:30. So may I invite Dr. Ashok Gavaskar to have an initial lecture on principles of correction of deformities, proximal tibia, interarticular malunions and non-unions. Over to you, Dr. Ashok Gavaskar.
Thank you, sir. Am I audible?
Yeah, you are audible very nicely without anything.
Yeah. Okay. Thanks, Dr. Chanda, for having me here, and thanks Ashok Sham and others for putting this program together. And welcome Professor Kretek from Hanover. And I don't know whether Dr. Kretek remembers me, like I did my trauma fellowships with him in 2014. So at MHH. So it's great to have him here. So I'll just get things going with a small talk on how to approach malunion after tibial plateau fractures by using corrective osteotomies. What are the management principles and techniques involved? So if you look at tibial plateau fractures, they are relatively common articular injury in the lower limb. Since they are articular fractures, if you want to get an ideal outcome, the goals for any articular fractures have to be met. That means you need to get your articular congruity right. And more important, since it involves the lower limb, you need to get the axis right as well. I'd probably say getting your axis right is more important than getting your articular congruity right. And if you do not get these goals, these fractures can go downhill, and arthritic changes are visualized in up to 44% of these patients. after a malreduction. Not necessary that all these 44% of patients are asymptomatic, but some of them may be. So it is important to get it right the first time. If you look at the problem of malunion after a tibial plateau fracture, in terms of treating them, there are no standard guidelines because these problems are not very commonly addressed. So treatment has to be taken on individual basis. If you look at the complaints of these patients, they predominantly present with a valgus deformity because lateral side malunion is much more common than the medial side. And these patients have a complaint of a bony pivot. That is the most commonest one that we can see because often these patients have a malunion following a split depression fracture pattern. So these patients often have a dent in the articular cartilage, which sort of gets them a bony pivot whenever they try to weight bear on the injured limb. They can also have varying degrees of giveaway, indicating instability due to either bony or ligamentous or both components. These patients often present with pain as well. And if you look at the range of motion, they are pretty well preserved most of the time. And in terms of treatment, if you are encountering a patient who's relatively elderly or you have a younger patient where you have an irreparable deformity, getting a replacement or a fusion done depending on the kind of patient that you are dealing with is more wise option. But if you want to undertake osteotomies in these patients, then you need to choose them really well. These patients need to be young and these deformities have to be undertaken relatively early so that you are not looking at long-term or widespread cartilage damage and you can get a reasonably good correction at the earliest. So the question is, how early can you do an osteotomy or how late is it effective? Like how long can you do an osteotomy and still get good results? If you look at the medial side injuries, they tend to be pretty unforgiving. They can be rapid progression after a medial malunion. But on the lateral side, if you look at most of the chondral segments are depressed and these depressed segments tend to be unloaded and they can be intact for a long time. And that is what the paper from Rennie Marty, probably the largest series on this topic, tells us. They looked at 23 patients of whom they operated at a mean of 16 months after injury. And if you look at, they had followed them up to 13 years of follow-up and they could see no progression of arthritic changes in 16 patients who had a lateral side injury. So these patients can be undertaken relatively late also compared to a medial side injury. So what are the issues that you need to consider, how to evaluate your patients before undertaking these massive corrections? First thing is to rule out infection, because if you have an infection compounding the problem, then it's a completely different ballgame altogether. So you need to make sure it is not infected. And then you also look at other issues because these patients might have undergone more than one surgery, it may have been open injury to start with. So you need to counter poor soft tissues. There may be multiple hardwares and multiple scars that need to be tackled with. Of course, you need to have a look at bone stock as well after multiple surgeries. And there may be issues like knee stiffness, which might have to be tackled with associated procedures, especially these are common if you have an associated distal femur or a patellar injury. So how to plan for these fractures, malunion? The key thing is to get good x-rays done. Standard AP lateral radiographs are enough to identify and diagnose the injury. Long leg radiographs are important in quantifying the amount of deformity in the axial plane, both coronal and sagittal. You can take chest x-rays also to quantify the amount of bony and ligamentous problem present and also to assess the joint congruence. CT scan is required and can be very useful when you're dealing with intra-articular malunions. The role of MRI is questionable. We also do 3D printed models whenever available, especially when we are dealing with a complex deformity. This can help you play around with the deformity, plan your surgical approach and the strategy as well. If you look at principles of treatment, it depends on what kind of malunion you are dealing with, whether it is an extra-articular malunion or an intra-articular malunion. Intra-articular malunion can be a split malunion, a split depression type after a lateral spine injury, and sometimes it can be complex involving all components. And most often you will be dealing with malunions that have both an extra-articular and an intra-articular component to it. Surgical approach, they are standard approaches that we use in fresh tibial plateau fractures. For medial side, you can use posterior medial exposure, which will give you access to the medial column and also the posterior part of the medial part of the posterior column. If you want articular exposure, you can get it by making sure you take care of the deep MCL and work on both sides of it. And if you are embarking on a slope correcting osteotomy, an anteromedial exposure can also be very useful. For the lateral side, standard anterolateral exposures are enough most of the times, but if you are dealing with very complex malunions or in the posterolateral malunions, you might require osteotomy of the Gerdy's tubercle or the fibular head or both. And if you look at literature, osteotomy of the patella, tibial tuberosity, and even taking down of the patellar tendon have been described. So it depends on the kind of deformity you are dealing with. The surgical tactic with regards to correcting malunions would be like, if you are dealing with an extra-articular malunion, from the medial side, they're relatively simple. Everybody is aware of how to do an HTO. Most often that is suffice for treating extra-articular medial side tibial malunions. Only thing that you need to remember is like, sometimes you may have to include the tibial tuberosity as well when you are doing large corrections. This is to avoid lowering of the patella when you undertake huge corrections after post-traumatic lesions. On the lateral side, for both extra-articular, definitely, and for some intra-articular corrections, you have to do a fibular osteotomy as well. With regards to intra-articular lesions, on the medial side, most of them are coronal medial splits, which will require a direct exposure into the articular surface to make sure you have reduced them well. Make sure you protect the deep part of the MCL. Ephemeral distractor is extremely useful to gain length and also to work on either side. For the lateral side, I would say 5 steps. You start with the fibular osteotomy. As I said, it is definitely required for an extra-articular deformity and also for a lot of intra-articular malunions as well. The second step would be a varization extra-articular osteotomy, followed by demarcation of the depressed articular surface and elevating it, and then support these elevated articular segments by wedges or grafts, whatever you can, and finally complete your fixation. So just to summarize the steps on the lateral side, these are images taken from Rennie Marty's paper. As you can see, it starts with the extra-articular varization osteotomy, and then you open it up and then expose your articular surface. He describes a technique where you use multiple K wires to demarcate the depressed articular surface and then tamp it from your site of your osteotomy. And once you have done it, you can support the defect by grafts and then complete your fixation. But this is one way of doing it. You can also do intra-articular osteotomies. But at the end of the day, these are the principles that you need to remember. So I'll just show you some cases. Like this is a 22-year-old male who had a 9-month-old injury, and these are his x-rays. He had a foot drop as well in presented to us. He had a varus deformity. His ROM was normal. He also had a posterolateral instability, which an STO will address to an extent as well. So these are the CT scans. Like so even though this was an intra-articular injury to start with, his deformity right now was predominantly extra-articular. So we just took out a simple HTO like correction, and this is what we ended up with. And this is the immediate post-operative correction, and this is in at 6 months. And around 6 to 7 months, his foot drop recovered as well. Even though we didn't do anything about it in the initial surgery, his foot drop recovered as well. This is another male, a 17-year-old, 4 months old injury, a varus malunion. His ROM was again normal. In this case, like again, if you look at the fracture configuration, it's like sort of a isolated medial condyle injury. We initially thought of doing a Miyamoto-like type osteotomy because, as you can see on the medial side, the joint congruence appears wide. But then, like I wasn't very sure about the Miyamoto type osteotomy, so I went again with the simple HTO type. And as you can see, like we have got a good correction, and the joint congruence now appears pretty good as well. So this is a case of a 19-year-old female with an 8 weeks old injury, not necessarily a complete malunion, but sort of a nascent malunion. She initially had a posterior column fracture, complete posterior column. You can see the posteromedial component. You can see the posterolateral component as well with a posterolateral central depression. So this was initially treated like this using a medial construct. As you can see, complete malreduction. The medial side shows a huge step off, and there is a bit of varus as well. So since she was just like getting into a final stage of union, it was pretty easy for us to take it down. So we took down the malunion or impending malunion, then corrected the medial side completely, and then this is what we ended up with. We used the reverse L approach to get access to the entire posterior column, medial side correction, lateral side correction, fill it with bone grafts, and then complete our fixation, and then we get our access right as well. This is a case of a 30-year-old male who had a lateral column fracture. He underwent ORIF around 7 months ago. As you can see, the CT scans of the initial injury. And this is what he ended up with. A plate on the lateral column. Reduction is questionable. You can see an articular step off, and you can see the axial valgus deformity as well in the coronal plane. So again, same principle that I spoke to you about. This is the post-reduction CT scan that you can see, appreciate the malunion over there. Again, this is the exposure with the Gerdy's tubercle osteotomy. Use of a femoral distractor gives you great access to the articular surface. Again, same principles, an extra-articular distraction, and then focus on intra-articular correction, where we do an intra-articular osteotomy using joysticks, control both fragments, clamp them together, and then complete our fixation after supporting those elevated condyle fragments. And this is what we ended up with. As you can see, pretty good restoration of the articular surface and the axis, we got it right. So this is a complex malunion in a 34-year-old. He had a posterior fracture dislocation type of injury 11 months ago. He presented to us with pain, deformity, and this is the CT scan that he presented with. As you can see, he's got a huge postocentral depression that the femur is articulating with right now, with the lateral condyle completely in a non-articulating position. And these are the 3D CT scans. You can sort of look at the components of his injury. So our aim was to sort of recreate those fracture lines and then correct the deformity and get the femur articulated to the tibia again. And this is how we undertook it, like medial side, again, use of a distractor, recreate those fracture planes, and then a conventional anterolateral approach on the lateral side. And these are the steps. First, we go on the lateral side, make sure you clear that gutter where the femur is articulating of all fibrous tissue, get the meniscus out, clean it up, get everything right, and then go to the medial side, recreate that coronal fracture line, followed by doing an extra articular osteotomy to sort of jack it open and get it aligned, and then finally complete your fixation. We also use a sort of a small cage to sort of support the medial side. And this is what we ended up with, pretty good correction. As I can see, there are definitely deficiencies on the articular side. There's not a particularly sort of absolutely anatomical articular correction, but we got us access right, reasonably good articular correction as well. And this is him at 15 months doing reasonably well, pain-free. So in summary, axial and articular deformities are quite common after tibial plateau fractures, and some of them can proceed on to symptomatic malunions. And when you are dealing with symptomatic malunions, treatment has to be undertaken on an individual basis. Monocondylar deformities are actually more troubling because they lead to more axial deformity than bicondylar ones. And some of these malunions may be complex, which requires excessive planning and expertise. These osteotomies definitely gives you pretty good results if you can do it earlier and well. Thank you.
Thank you, Dr. Gavaskar. You wonderfully elucidated a lot of principles and the surgical technique. So maybe have some discussion. Dr. Gavaskar presented with a case where lateral condyle was depressed, a very common scenario. So what does the faculty think? What was lacking in the initial fixation? Was it absence of graft, absence of good fixation, absence of folding? So if I can ask Professor Kretek, what would you think the lateral condylar depression initial surgery? Professor, yeah.
Professor, you're muted. Professor, you're muted.
You'll have to unmute yourself. Yeah.
Sorry?
Yeah.
Good. Thank you very much, Ashok. It was a fantastic presentation and bringing it really to the point. What I find is frequently the problem when I review cases is that the reduction is underdone. The lateral condyle on the tibia side is usually convex, and This is one problem. It's under-reduced, and one of the reasons for the under-reduction is that the exposure is too limited. I really love the posterolateral approach, which gives us full access to the entire lateral complex, and then you can judge the shape of the lateral condyle according to your pre-op planning, and this is frequently one of the causes of under-reduction, malalignment, and ligamentous laxity.
Thank you, Professor. Dr. Maheshwari, if I can ask, do you routinely graft these patients or use some bone substitutes? You'll have to unmute yourself, sir.
Yeah,
You'll have to unmute yourself, sir.
so lately I have not been using graft. I think I manage with grafting more often than not. And my key is that I must always overcorrect it. That means give the knee a good varus, either with a distractor or at least manually. My assistant should really give a good varus, and I want to push my lateral condyle as far up as possible. And I know some of it will collapse eventually, but it is the principle is overcorrection of the lateral condyle and not even only correction. That's my take.
Thank you. Yeah. Dr. Rajiv Rai, can I ask you, how do you judge how to place this plate? Do you plate absolutely flush to the articular surface? How do you judge that? That is many times difficult. Please unmute yourself, sir.
I usually have my the most proximal screw at least 1.5 centimeter from the articular surface. So I usually try to take a bigger chunk, because many times while elevating, one can crumple the bone if it is an osteoporotic bone. And I agree with Dr. Maheshwari. He says always overcorrect. I would go a step further and say, you can never overcorrect. Do as much as you want, because the femoral condyle is going to restrict your overcorrection. So you should try to overcorrect, knowing that you cannot malreduce in overcorrection. That is probably one good trick. But placing the plate usually is, the first screw should be about 13 to 15 millimeters distal to the articular surface. So that would be my position.
Thank you, sir. We welcome Dr. Tanna sir on this webinar. We had an initial lecture from Dr. Gavaskar, and Professor Kretek is already with us. We were just discussing the case Dr. Gavaskar presented of a lateral condyle which has gone for depression, and whether we graft in every case. That was the case being discussed. Let me, after this, we'll be having the lecture from Professor Kretek, who will be sharing his views on intra-articular correction of malunions. So it's my pleasure to introduce Professor Kretek. He had a residency done at the Trauma Center, Hanover Medical School. He was the fellow of the Royal Australasian College of Surgeons. He was professor and director of trauma, Monash University, the Alfred Hospital at Melbourne, and now professor of trauma and orthopedics at the Hanover Medical School. I remember last time in TraumaCon when he gave a distinct reduction technique for a subtrochanteric fracture, and I always used to find them difficult. He very nicely explained them with plexiglass model, and after that I had no difficulties in those difficult fracture reductions. Professor has special interest, and his research focuses on computer navigation and robotics, late reconstruction of articular trauma, which we are now going to see in his deliberation, and has a lot of interest in limb salvage, joint transplantation with large allograft, and 3D printing in orthopedic trauma. With this, may I present to you Professor Kretek. Most welcome, Professor. Please share your screen. We are all eager to listen to your work on proximal tibia malunion, the intra-articular correction, and the various options. Welcome, Professor Kretek.
Thank you very much for this nice introduction, and thank you very much to having you with you for this wonderful webinar. I really enjoyed already the first contribution from Ashok. And yeah, it's one of my hobbies in this busy trauma environment in northern Germany, which is a little bit different from what I have in an environment when I was in Australia. And it gives me a lot of opportunity for doing clinical and research work, and both are heavily linked together. And the topic for the next 25 minutes is intra-articular deformities, and I will outline our strategy, our recent developments based on 4 different cases. And we all know these problems are manifold. We have cartilage and bone problems. We have—
Professor,
yes.
Sorry to interrupt. We can't see your slides as of yet.
Oh.
Yes.
You can see it?
Not yet.
Oh, what do you want me to do?
Just share the screen. Below our videos, you can see the share screen, the green tab called share screen.
Sorry. Yeah. Now better?
Yeah. Yes, Professor.
Okay. Sorry.
Yeah, now we can see. Yeah.
Good. So intra-articular problems, we have cartilage and bone problems, alignment and stability, ligamentous stability are additional key points, and we have to have not only cartilage, also the meniscus also has an important role on both sides, medial and lateral. And many times these are young patients, so alternative for us arthroplasty in young patients is really what we are looking for. And I would like to sensitize you for new joint preservation, preserving options like intra-articular osteotomies, osteochondral bending and shaping. Sometimes we have grafts, but the shape of the graft does not fit where we want to place them. So can we modify the shape of grafts? That's a question. And everyone is talking nowadays about 3D printing. And I will share with you that this goes beyond printing fractures or deformity models. These 3D prints can help us as guides, as templates. So we can do 3D print template guided navigation, which is extremely helpful in complex deformity because it allows us to precisely place our cuts. And finally, sometimes we have situations where the deformity is so extensive that the destruction of the cartilage osteochondral situation is so bad that we cannot repair it anymore. We need to somehow replace it and using biological materials, allograft. I have no conflict of interest for a couple of paid editorial tasks that are listed here, or national and international patents. And the problems in orthopedic trauma have been nicely outlined by Ashok Gavaskar just a few minutes ago. We have cartilage damage, we have cartilage defects, we have joint destructions, we have alignment problems, we have ligament problems. And the problems with joint replacement in the young, especially in the young patient, is they have more implant loosening, they have shorter implant survivals, they have more and multiple revisions in a lifetime, and they get more and more complex and more complicated. And when you look in the literature, there's very few written on intra-articular deformities and intra-articular osteotomies. One of the very few papers was just mentioned by Kirchhoff and René Marti some years ago, and even they were intra-articular but extracondylar osteotomy. They moved the entire condyle as a piece, but it showed that we can really improves the patient's situation quite significantly. But the problem is many deformities are even more complex that they can be handled with the intercondylar osteotomies. Let me quickly step into what do we need in imaging. Of course, conventional X-ray and long-standing film. But I would like to focus on the fact that we can do nowadays easily CT scans. And I frequently see that we get images, CT data sets of the ipsilateral fractured and deformed side. But frequently, the healthy contralateral side ends up in the bin of the radiologists. And that's very, very pity, because the contralateral side gives us an enormous plenty of information, which is very, very helpful for planning, for judging the shape of the deformed bone, and it helps us to show and to plan where we want to go with our correction. So keep the contralateral side data set, which is in the ring of the CT scan anyhow, keep it for your evaluation and for your judgment. MRI is always said to be very good and helpful for the judgment of the soft tissue, which is cartilage, which is ligaments, and which is meniscus. But I find it often very difficult to read, because sometimes these tibia plateaus and these distal femurs are full of metal. So we have a scattering of signal, and it's very hard to read sometimes if this is a side effect of some metal or some defect of the cartilage. So I like much more the so-called CT orthography, a combination of intra-articular contrast dye given together with a CT scan. And look at these images, how nicely you can read the bone, how nicely you can judge the cartilage. Even the meniscus can be judged in parts. So I prefer for planning of complex intra-articular deformities, I love the CT orthography. Instruments, pretty straightforward, very important, the laminar spreader in order to open up osteotomy sites, to clean it out, and to make fragments, intra-articular fragments, movable. I actually would right away start with you with clinical cases. I have prepared 4 cases, and I would like to start with Jacqueline. Jacqueline is 50 years old, and she had a missed lateral tibia plateau impression fracture. That's her plain film. It was missed in the initial hospital, and she had her first X-ray several weeks after trauma, when everything was already healed. This is her lateral tibia plateau. You see here there's something impressed, something abnormal, and the CT scan shows it exactly, because this is the lateral condyle. We see the joint to the fibula, and usually this is some sort of convex. And when we see it here, this is the superimposed contralateral side, but with the ipsilateral side has this deep defect depending of where you watch it, and you see a deep concave defect impressed by the femoral condyle. And if we go to the AP view and superimpose the contralateral normal CT scan, we see healthy, but here in the ipsilateral side we see significant impression of the lateral parts of the lateral condyle. So this all has healed, but the patient has significant amount of pain, VAS of 7. She is unstable. She walks on crutches, and she presents 9 months after trauma. Everything has healed. So how can we correct an intra-articular deformity, a concave deformity on the lateral plateau? And when I was thinking about solution, I had these two things in mind. The one is the toy for children, which makes a rigid stuff, wood, very flexible. And this is something I learned in Asia, that if you cut in a certain way, you can bend and make concave structures to convex and vice versa. So these observations have stimulated my planning for this case. And I was doing experiments with a reciprocating saw, cutting multiple times just underneath the cortex and a little bit inside the cortex. So to make multiple cuts, and the multiple cuts, like in the fish, all of a sudden get flexible, get bendable, so we can go underneath with a destructor and fill it up with bone graft. So this was the theory, this was the idea. Let's have a look how we do in this case. Here's the preoperative situation again. And here, the postoperative situation, what we achieved, we were able to make the concave deformity to a convex shape in both planes, AP and lateral. And here, the MRI before with the concave defect, which was then nicely elevated. So here, the situation, pre and post-op films on the lateral view, nice convex correction in both plane. And we have done an MRI before and after osteochondral bending. Here's the views 1.5 years after this surgery. The bone has nicely healed and the patient has significantly improved. Her VAS scale became much lower and her Lisholm score increased to 81. Not perfect, but significantly improved, especially in terms of pain. So if this works, I would like to share another case with you where osteochondral bending might be an option. And this is Uwe. Uwe is an anesthetist in a neighborhood hospital, and he sustains this lateral split impression fracture of his proximal tibia. Here's a preoperative film. Underestimates the amount of deformity, but when you see the CT scan, you see this significant anterior destruction. So one of my consultants took him to theater and fixed him, and these are the post-operative films, and we see something is behind some metal. And the real information we get again from the CT scan. And what we see is we have a normal structure here, but in the middle of the lateral plateau, there is impression. There is no cartilage situation. So we decided we bring him back to theater, and with something in mind, which always drove me when I'm operating proximal tibia fracture with the posterolateral approach. There you have access to a joint, and you can use the articular surface of this joint for small or medium-sized reconstruction. And we have two types of fibula. We have a concave type of articular surface, and we have a convex type of articular surface, and usually we need convex type of grafts in the lateral plateau. So let's go back to Uwe. See, there's a significant articular defect where there is significant articular deformity, and when we draw a line with the shape of the contralateral side, we see not only the defect in the anterior and middle part, we also see that the posterior part is slightly depressed, and this needs to be addressed with a chisel, and the posterior part needs to be elevated. And the best way to do this is to approach it with posterolateral approach, because you then see the entire lateral condyle in order to judge curvature, etc. Here on the right side, we see now, our first intra-articular view at the revision. Here is posterior. This on the right side is anterior. We have elevated the meniscus, and we see part of the meniscus is trapped into the joint. And this is something which is would not promise a good result. So we mobilized it. We mobilized a piece of the articular surface of the proximal tibiofibular joint. It was a convex type, and we have then identified, and multiple cuts from the bone side make this all of a sudden bendable. As you see here, it's concave, but we can flex it. We can make it concave, we can make it convex as we like. We can play with it, but the cartilage always stays intact. So we can replace some of the defect with this graft. And you see here the molded osteochondral fibular graft covers large part of the defect, and all of a sudden this joint again looks like a joint. The hardware was left pretty much in place, just the screws have been newly placed, and that's the postoperative CT scan. In comparison to the preoperative CT scan, we see good elevation of the joint in both planes. We have some, again, some sort of a neutral or semi-convex plateau. And here is the patient 1.5 years, 4 years after surgery. He is a runner. He resumed running again. Very happy patient, no pain, good daily stability, Luzon score 96 of 100, good Tegner score, and he is back to anesthesia and running sports again, and all covered with this small graft obtained from the proximal tibiofibular joint. Another case, and I would like to share this case with you because it shows very nicely the benefit of 3D prints. This is Mohammed. Mohammed presented first when he was 24-year-old, and he has sustained a B-type femoral fractures, which was malreduced in Varus in Libya. And he reported a pain level between 6 and 8, and this was also healed. He presents 2 years after trauma. We see here on this photo this varus deformity. We see on his first X-ray a fracture which has been stabilized with these conical screws. We see also some shrapnel, making any MRI very, very difficult. But when we look at the CT scan in combination with intra-articular dye injection, a CT arthrogram, we see very nicely his problem zones. The problem is joint incongruency. We see steps, defects, and interruption of the cartilage. His meniscus was pretty much intact, and also we use 3D analysis of both sides in order to judge the amount of correction we need. So we have superimposed the 3D data sets from the healthy side, and the healthy side is gray and the injured side is green. And so we see very nicely that we have about a shortening of almost 10 millimeters in both plane. And not only that, we also have some additional bumps, intra-articular bumps, which cause additional pain and problem. And this 3D data sets, as you see here, can be nicely used to play on the screen to do virtual osteotomies in order to end up with something which closest fits the contralateral side by comparing the green fractured side together with the gray normal side. So this is very, very helpful. And based on this, we can construct targeting aids made from plastic, which can then be sterilized and used intraoperatively as guides for osteotomy, as guides for reduction, and as guides for implant placement. So I'm quite sure that for my generation, it is enough to do email and Word and PowerPoint, but I really would like to encourage future new generations to play with this software, to learn it, because this will be the basis in the future. The future will be 3D, not 2D anymore, and we need to learn this, and these are instruments for the modern orthopedic surgeon in order to better understand deformity and to better understand and to make better solution for this problem. So we corrected this case in 6 steps. Step number 1, we created the distal master block, and the distal master block perfectly was complementary in shape to the distal malunited fragment. And it is nicely to reference because we just use the holes of the screws which were removed. Then we need a connection block to the proximal master block, and then we have 2 referenced structures on the bone. And step number 4 is adding cutting block to the proximal master block, which nicely defines the cutting plane, and we can virtually and in reality then nicely and very precisely cut this bone with not so much soft tissue disruption and not so much uncertainty, which we would have with normal planning and performance. And here we have a reduction block in step number 6. A reduction block has these connectors, and the connectors snap into the proximal master block and they snap into the distal master block. And once this fits with this reduction block, we know the amount of reduction is done, because it's a deformity in multiple planes. It's shortened, it's rotated, and it's also deformed in valgus and sagittal plane. So here some intraoperative shots after arthrostomy. We see. Sorry. We see the old heel fracture line. We see the bump here, and we do the different steps we just saw. Here is the complementary surface to the deformed condyle, which snugs in very nicely. This is connected with screws to the bone. And then we do similar things on the proximal screw holes, add the osteotomy block. This is before cutting. And then we use the oscillating saw along with the osteotomy, and now we have loosened the malunited fragment, and we can manipulate it, we can shift it, we can rotate it, we can put it more distal, and this is controlled and supported with the reduction block. The reduction block, as we have seen, is snagged into the proximal and distal master. So there is only one position which fits the perfect reductions, and this is additionally controlled with the alignment rod, and then we can go on for fixation. Here, angular stable plate, but still we have to address the local bump, which needs correction. We do a wedge type of osteotomy, here a closed wedge type, and here after removing the wedge, we just bend again the the osteochondral fragment, and we press it against the femoral condyle. So we have again removed the bump, and we fix it with the low-cost titanium K-bars in order to minimize the amount of implants. Looks the shape, it looks nice again compared to the preoperative bump here. Additional cartilage with ACT, chondral graft, and this is sutured in. And look at the postoperative imaging. We have now a perfect knee alignment axis, a perfect mechanical axis. We have a good restoration of the shape in the lateral view. The bump is gone. The radius of the distal femur is now restored again. And when we look at this here, we see a nice curvature of the distal femur. Here is a titanium K-bar, and look at the shape, very nicely achieved the normal radius. Here we have the screw. The screw worked as a spacer in order to prevent mechanically from closing the gap and which has an additional strengthening effort to the construct. Here's the situation in the CT scan. Again, green is the preoperative trauma side. Gray is the postoperative side of the same side. And look how nice the both surfaces match to each other. Gray and green is comparing preoperative planning and postoperative CT scan. And this shows that it could be nicely been achieved. Here's the situation. Walking the patient down the stairs with pain and instability. At 1 year follow-up, the Lysholm score increased from 80 to 100, and knee society score also significantly increased, and pain has significantly decreased. Very, very happy patient. And the final case really shows that we also need sometimes solutions when we have large combined defects, like Irmgard. Irmgard is almost 60 years, and she presents again very long after her initial trauma, horse riding accident with significant pain, VAS up to 8, instability. She is dependent on crutches, has an increasing valgus deformity, as we see here, and a recent arthroscopy and partial implant removal had no effect. And everyone whom she contacted initially told her, you need a total knee replacement in order to solve this problem. But someone gave her my address, and we did a thorough analysis. She not only had a large defect in her lateral plateau, she also had a non-union in her tibia plateau. So I was thinking on osteochondral allograft transplantation, but before you do this, you need to have a real good ground for the transplant. But once you have achieved this, the data from the literature shows that transplant survival is not only short-term, but also long-term, up to 15, 20 years. And if you use a fresh, thin osteochondral allograft, as the data seem to be quite okay. But in many trauma situations, we need larger cover. So we developed this Floxat concept, fresh, large osteochondral shell allograft transplants. And this is something I would like to highlight here based on this clinical case. So Irmgard has this large defect, and in step number 1 of the 2-step reconstruction was to build up the defect with a large autograft from the posterior iliac crest and let it go for 6 months to have ingrowth. And we overstuffed it in order to have really filled the defect. So we filled this large 4 by 3 by 4 centimeter osteochondral defect and addressed this way also the non-union she had in the posterior aspects of this proximal tibia. And once this was healed in, based on CT scans, we did planning for the osteochondral allograft together with the lateral meniscus, and 3D data analysis supports this very nicely. Here, the intraoperative situation at the transplant day, we had done a posterolateral approach. This is the transplant. This is the graft, which was then trimmed together with the lateral meniscus. So she got a chip, which is fixed with 1 screw and 2 titanium K-bars. This is the border between the graft and the transplant, and there is a lot of inherent stability, so you don't need much more fixation other than the screw and the K-bar. This is her 12 months after trauma, which good increase of her functionality. And look at her, how she is running up and down the staircase. Look at the X-rays before with the large defect and after a transplant. And she had a good and sound ingrowth of her bony part of the transplant. And not only it looks good on radiograph, but also her functionality is good. You can read her on the Knee Society score. We have now 60 months follow-up, which is 5 years. Both very good values, both on Leisholm score and Knee Society score. And really the worst case for a knee is being on a trampoline, especially if you are on a trampoline with other persons. You need a lot of coordination and you need a lot of trust in your knee performance. And we scoped Ingrid 1 year after her allograft transplantations, and look at this arthroscopy video, the indentation test with palpating hook. It's a very nice and soft feeling, which represents almost normal cartilage. The lateral compartment was very nicely, also the meniscus had a good stability, and we took out a little biopsy of her cartilage and sent it to the lab in order to check what cells are these. Are these still donor cells, or are these recipient cells which have with a chimerism been replaced over time? And the result was that 32% of her donor cell cartilage cells were exchanged with her own cells. So let me summarize. Intra-articular deformities, post-traumatic intra-articular deformities are complex problems. They are not only related to cartilage, but also to alignment, ligament stability. Meniscus are important options. And there are some new ideas for addressing these big problems. For example, using the proximal tibiofibular articular surface and to do some osteochondral bone shaping. There are new options on the horizon with 3D printed templates and template assisted navigation during osteotomy. And finally, allograft transplantation. It's an old method, but I think there are still good arguments in order to reuse this with modern techniques in order to be able to help our patients with difficult intra-articular problems. Thank you very much for your attention.
Thank you, Professor. That was an awesome presentation, and you gave us a lot of options for intra-articular correction. May I invite Professor Tanna's comments on this presentation? Professor Tanna, please.
So you asked me that if it is in reserve, you told me?
Yeah. But the comments on Professor's work, your comments on his...
Yeah, I think, Dr. Kritik, I think you really made us feel primitive. Because I think I feel we will probably not be seeing it. Even our youngest faculty also won't be seeing it in his lifetime, probably. I hope he'll be able to see it. It was something terrific, and we didn't realize that this can be done. Now you have made us feel, so I'm sure Ashok, he is going to really pursue that. He is our youngest faculty probably, and he is going to pursue that. Ashok?
Sir, I was there when Prof was like embarking this flock set technique some years ago. But like he told me, but I have not seen it. When I was there for the fellowship, he was telling me about the flock set concept, but like I didn't see a case at that time. Hopefully. Because
when he came to TraumaCon, he again exploded like anything, and we just didn't know what he was talking about. And then it was something which was a really eye-opener. Thank you very much, Dr. Kritik. It was really superb. Nice seeing you again.
Yes,
thank you.
Absolutely. That was fabulous. Thank you very much, sir. Now, the reality in India is multiple. We have patients who are coming late and not resource poor situation and the conditions here. With these situations, how are we managing our cases? Let us see and share our cases also. May I invite Professor Maheshwari to present his case, which possibly he has...
Yeah, okay.
Yeah. Can you
Hi,
share your screen?
Jitendra.
You have to unshare it.
Yeah.
How are you, Jitendra?
All well, sir? Everything all right? How
Good.
are you doing?
Good.
Yes.
So...
Now you can share your screen, sir.
Okay, I'm sharing.
Yeah.
Can you see something blank is there?
Yeah.
Okay, so let me go back to the first one. Okay, so
Yes,
first of all, I can't not comment on what Professor has shown us. It is amazing. It is unimaginable, I would say. And what Dr. Tanna said is perfectly all right. I think tonight I will dream how he was doing what he was doing to actually understand it properly. And I have questions which I'll ask maybe later after I finish my presentation. So I will present this case which was very peculiar in my last 30 years of experience, and maybe some points will be highlighted. So I saw this 20-year-old who fell from a scooter and sustained knee injury. Very typical in India. Huge knee swelling, grossly unstable knee it was. That's not the time I saw him. I saw him later. There was wounds over the knee as expected when you fall on the roadside. And that was the X-ray done at that time, which showed a lateral condyle fracture there, depressed on the posterolateral aspect. And the surgeon did a CT as well, which is very good. Now we are doing more and more CTs in this country. Earlier, that wasn't the case. And you could definitely pick up a lateral condyle fracture, comminuted posterolateral there. And because there were wounds on the knee, and the surgeon probably didn't know what to do, and so he did an MRI. That's also something is done very commonly in India. And so there was MCL, which was also torn. ACL was torn as per the MRI report, and there was a lateral meniscus tear. So that was the complete picture of a lateral condyle fracture with a MCL injury, with a ACL tear, with a meniscus injury, lateral meniscus injury. That's how this patient presented to the first surgeon. Because there was wound on the knee, he decided to just give a slab for 2 weeks. Obviously, there was wound, so he didn't want to do anything surgically. And at 2 weeks, the plaster was removed. And this is the time he presented to me. 2 weeks later, after the primary treatment was done, nothing active was done by that surgeon. And at that moment, the patient was not able to walk due to pain. He was barely walking with crutches, and knee range of motion was 10 to 80 degrees. And clinically, there was a medial side opening and also gross ACL deficiency. So this is what it is. 20-year-old, 2 weeks down the line, nothing much done, fairly nicely investigated. And just to summarize, if I can say, 2 weeks old, ACL plus MCL injured knee with rim fracture of the lateral posterolateral condyle with a lateral meniscus injury as per MRI and a range of motion of 0 to 80 degree. Now that was the situation, and if I can ask the faculty, these were the four options I thought at that time. Doctor, is there a time to get into discussion at this stage?
Yes. We are going to discuss the cases. Now, can I ask Dr. Jignesh what he would be doing for this case? Dr. Jignesh, please unmute yourself.
Yes, sir.
Yeah. You have seen the case, you have seen the X-ray.
Yes, sir.
15 days down the line. Yeah, please.
Patient has ligament injury with the condylar fracture.
Yes.
So everything cannot be addressed at the same time. That is what I feel. So mine will be 2-stage reconstruction of the knee joint. I will, So I will evaluate in form of CT scan. And
that was done.
Yeah, that was done. Yeah, I saw it. I will elevate and reduce a lateral condyle perfectly well, fix it up, and do everything, reconstruction, articular reconstruction perfectly well. Then make an arthroscopic evaluation. And I will reconstruct the ligament, MCL, if it is very lax, after reconstruct lateral condyle, I will reconstruct MCL at that stage. But I will leave the ACL. ACL and lateral meniscus, if some meniscus osteotomy is done, and then lateral meniscus repair can be done at the same time, if under vision. Otherwise, I will leave it to arthroscopist, and arthroscopist will secondarily assess and repair lateral meniscus as well as ACL second stage, once the lateral condyle fracture unites.
Perfect. Dr. Rajiv Rai, you wanted to comment on that?
I agree with Jignesh completely. I would do an arthroscopic evaluation. I would reconstruct the bony element and consider the ACL at a second stage. The lateral meniscus would be tackled at the same time at the first stage.
Okay. Gadegone sir, you wanted to opine on this case?
I will go for two-stage technique. Two-stage, first lateral condyle reconstruction and concentrate on medial collateral ligament and leave it for the arthroscopist to do anterior cruciate ligament reconstruction.
Right. And Dr. Jawahar Jetwa sir, your implant of choice for this fracture fixation, which is small spicules of bone and lateral rim fracture sort of phenomena?
Yes, I think once you open up on the lateral side, you have an opportunity to look at the fracture reconstruction as well as the status of lateral meniscus fully. You can repair lateral meniscus at that time because you have everything open. Now the point is that if the fragments are quite good enough, then you can put couple of screws only. But if you feel like that underneath the bone, which is primarily, it seems like the majority of the weight-bearing area is not fractured, it is the rim which is fractured. In those cases, you can go away with only screws. Otherwise, you have to put a plate and put some bone graft there.
And ligaments would like to tackle later on?
Yes, ligaments like ACL, naturally, it is a second stage. But on the medial side, after this reconstruction, one has to check intraoperatively how much is the laxity. Because sometimes it happens that after reconstruction, the picture is a little bit different. So you may not or you may repair on the medial side.
Tanna sir, your experience on these cases, ligamentous as well as bony injuries? Tanna sir, if you can have your opinion. Sir, you are muted. Can I ask Professor Kretek what he would like to do in his experienced hands? Dr. Kretek, please.
Yes.
Yeah.
Can you hear me?
Yeah, we can hear you.
The skin and the wounds are healed nicely.
Yes.
Okay, I think I would go pretty straightforward for addressing all three lesions in one session. I would make a posterolateral approach to addressing the rim fracture. Use this access to address the lateral meniscus. Would not reconstruct, but would brace the ACL and suture the medial collateral ligament. That would be our approach.
Okay, thank you, Mohsen. Can you proceed, Dr. Maheshwari, with what you had done? Yeah.
Okay, so what we did, I wasn't sure what I'm going to do, and I always have this tendency to look inside the knee as to what's happening inside. That's a great opportunity before you take a final decision. And this is almost always I do an old case of knee joint. I always look inside the knee, and often I find surprises which I could not make out by any investigation. So there was a complete MCL which was expected. There was a complete ACL expected, and also a partial PCL. It was lax but not really torn. But what was funny was lateral tibial condyle cartilage was badly damaged. It was like flakes of cartilage coming out. Almost 70 or maybe 70% of the tibial plateau was off cartilage. And the damage to the bone was so bad in multiple pieces. And there was a complex lateral meniscus tear. I couldn't save it. So obviously in this arthroscopic scenario, I did a lateral meniscectomy. There was no way of saving that meniscus. I did chondroplasty, and I was wondering what to do with this condyle. What will happen, whatever I may do, how will this patient walk? What will he feel 5-10 years down the line? And then I looked at his other leg. His other leg was in valgus. And I knew this leg was also in valgus preoperatively. And I knew whatever I may do, whether I can make this knee painless with that kind of injury, with meniscectomy, everything may be a little difficult job for me. So I did nothing to the lateral condyle and to the ACL and to the MCL because I knew that it's already 0 to 80 degree movement. If I do anything, I might actually make it a stiff knee. That's something most my patients don't like. They don't mind an unstable knee, but they cannot accept a stiff knee. So I kind of stopped there and I did that surgery, only arthroscopic meniscectomy, chondroplasty, and thought I'll take my time to think what to do next and discuss with the patient all the possibilities. Now, after 3 months of physiotherapy, that's how this patient was walking. The knee was going into valgus. His problem was instability. He could walk barely like this, but every time he would walk, the knee will go on the valgus. Because I've obviously done nothing for the medial condyle, lateral condyle, as well as nothing for the MCL. But I knew if he keeps walking like this, apart from instability, he's of course going to develop pain sooner or later. So my question was at 3 months down the line, and I couldn't have the courage of fixing everything on day one, fearing that it might get stiff and fearing that let me just take my time. So at 3 months, it was essentially an unstable knee. Lateral condyle rim fracture was there as it is, obviously contributing to instability, and moderately damaged tibial cartilage, which I'd seen with my own eyes. Lateral meniscectomy was already done. ACL, MCL deficiency, patient is walking on valgus. Now, what good is this lateral joint to me in short term and long term was my question. Okay. So I again thought, what do I do? Do I reconstruct everything now? Now that I have a good range of motion and lateral condyle can be fixed, I can maybe do some grafting and fix my MCL as well as ACL and do everything, or reconstruct in 2 stages. That means only fix the bone first and I'll look after the MCL and ACL later. Those were my options. But looking at the condition of the joint from inside on the lateral side, with no meniscus, with cartilage gone, with a valgus knee, patient walking on a valgus knee, I knew that if I don't shift the line of weight bearing from lateral to somewhere midline or medial, nothing will work. This patient will remain unstable, whatever I may do. So that is what I did. I did a weight bearing X-ray and a long X-ray, and you can see grossly valgus alignment of this patient. And so I did a varus osteotomy, supracondylar, because I knew this lateral condyle or lateral compartment is of no use. It is contributing to instability now. It is contributing to degenerative arthritis in future. And if one operation where I can make this patient stable and maybe delay his osteoarthritis to some extent for at least a few years would be just change the line of weight bearing. And I may come in and do a ACL reconstruction if he's still unstable. So that's what I did. And this is how the leg looked. You can see the other side is valgus. And I have no kind of confidence that if I reconstruct the lateral side to start with, whatever I may do, I leave that knee in valgus. Sooner or later, it's going to be painful on that side with meniscus gone and the cartilage gone. So this is what I did. The line of weight bearing was midline, more or less, slightly 1 degree varus maybe. And this is what I did. And then I was asking myself, what do I expect from this patient? Deformity is corrected, maybe a little bit varus it is now. And will he remain unstable? Will I have to go in and do ACL? And deformity is, of course, now corrected. But will he become painful and stiff still? And or something else will happen. So after finishing the case,
before your final results, sir, may we have some comments on what was done? Dr. Gavaskar, would you have agreed with this treatment, or would you have done something different? Yeah. Can you unmute yourself, Ashok?
Yes, sir.
Yeah.
Okay. Actually, I'm not really sure. I think like the initial injury, like I think I would like to have a better look at the bony component. Actually, like that wasn't very clear to start with right from the start. That is one.
Can we have the CT cut, sir, before? Yeah. This was,
yeah. So I think like even though the injury is on the rim, I think he's got a significant injury. I think that there are definitely more to it than what we see on the CT scan. I think this is probably this is where we missed the plot. And did he said when he scoped him, like was there a posterolateral corner injury as well?
This was a bony instability. There was no bone on the posterolateral part. So that will obviously give rise to.
So the posterolateral structures like intact, is it?
I mean, you can't make out. With a bony injury, you really can't make out that part.
Okay, perfect. So Ashok, what would have been your fixation modality here if you would have fixed this? You will have taken which approach?
No, as I said, like, no, I think like I would have done a posterolateral approach. Like I would have probably taken the fibular head osteotomy and then get access to that area, and then probably like I think like it is very peripheral. So and then probably elevate and then get some mini fragment screws in and then get everything together. But and I think like and even on these CT scans you can see the medial side opening up as well. So it might be a pretty high grade MCL injury also. So probably our tendency would be to repair it in first stage if it's an high grade injury, especially monocondylar injuries. A lateral condyle fracture with an MCL injury after reconstruction, if it's still unstable, opening up on the medial side, we will go and repair it at the same stage. Otherwise, we'll brace it. So that is how I would have approached it in first stage and then followed by intra-articular reconstructions.
Okay. Thank you, Ashok. Tanna sir, your comments on managing this patient? Tanna sir, are you with us? Possibly, Tanna sir is.
No, I'm
Tanna
here.
sir, yeah. So
I want to ask Dr. Kritik, in his setup, with his all his gadgetry, how would he handle this now? Dr. Kritik?
Yeah, good point. First, it shows that these rim avulsions, they are. Can you hear me?
Yes, sir. Yes. Yeah.
It shows that these rim avulsions or rim impressions, they have sometimes on X-rays or CT scans only minor bony defects, but they are very severe injuries because of the ligament osseous complexity. And I think I still would follow my initial strategy to approach it from a posterolateral approach. I would, if I was not aware that this is crushed cartilage, but I would consider using my proximal fibulotibular joint as an option for osteochondral replacement, and then fix the fibula with a screw to the tibia. As long as the medial collateral ligament is not fixed, as this will always be unstable. And I think with ligament bracing for the ACL only, not for the PCL, but ACL only, there would be sufficient stability for after treatment. With the meniscus, probably would like, for any instances, try to avoid to do complete lateral meniscectomy. I would try to keep whatever I can keep, but sometimes the situation is very disastrous.
Chandak sir,
Please go ahead.
I actually do not think this is a sort of a lateral avulsion injury. Actually, if you look at the mechanism, like you got a tension side on the medial side, the MCL is gone, no ligamentous injury on the lateral side. Okay, it's sort of a depression with a sort of a combination of shear, like with that sort of sheared off the posterolateral rim there. Okay, I would look at this as more of a depression injury on the lateral side if you look at everything, but probably the initial images aren't completely adequate to deal with it. So I really don't think it's a lateral avulsion injury.
Okay, so you would have gone for a fixation with a good rim plate?
Yeah, I think I would think on those lines, like, and definitely I would probably require a few more images on the CT, and then it would be, as Prof said, fibular osteotomy or some sort of a postlateral approach, get the joint right, and then an MCL repair as well.
Yeah.
So by repairing the MCL, how much benefit do you get?
Sir, one thing, like, we don't repair all MCLs, but like if it's an high-grade injury, okay, especially like if it is a avulsion from the bone on the femoral side, it probably makes sense to go and repair it. And then you restore stability. You also decrease the forces on the lateral side, and then you can mobilize them as well soon. So I think like that is our strategy in monocondylar injuries.
Because when the MCL is injured,
it's difficult to assess.
Because when the MCL is injured, there is also a plastic deformation of the MCL, as we all know about it. So in the plastic deformation of the MCL, only end-to-end suturing is not going to get you much. So are you going to also any of the tissue graft or anything, you're going to do that?
No, that is what I said. Like, it's predominantly bony avulsions. So if it's like a mid-substance tear, then probably, as you said, like, we can leave it and we can wait and watch. But if you have done an MRI, if it's a bony avulsion from the femoral side, if it is after you fixed your lateral side, is really unstable on the medial side, you can go over and do something about it.
But are you feeling a bony avulsion on the MRI or CT?
No.
Dr. Mageshwari sir has said.
No.
It doesn't appear to be, no?
No, there's none. No. So can I ask Professor Ketrick this question? So once you have seen, so one of my observation, which I've seen very often, that when you have a bony injury, there's a lot of soft tissue injury or cartilage injury, in fact, which you can't see by any method preoperatively. In a fresh case as well as in a little bit late case, good thing I learned today is the CT arthrogram, but that is always an issue, and especially a case where the lateral compartment is almost brutally damaged, no meniscus, I couldn't save that meniscus, no cartilage on tibia, peripheral rim gone, I may reconstruct that, MCL on the other side gone, and the patient has a predominantly valgus alignment. This is a recipe for failure of everything, because I do a lot of sports surgery also, and we know when you reconstruct MCL on a valgus knee, it's a failure. You have to change the alignment in favor of the ligament. So that's where I thought, if I don't do alignment correction, because he was primarily valgus on the other leg as well as this leg, nothing will work out for me. That's what was my thought process.
Professor Kretek's opinion, sir?
Yeah, I think it's a good point. I wasn't aware that he had initial this valgus deformity brought with him, but I think in the acute trauma situation, it's a bit different from the elective situation, and everything which helps to improve ligamentous stability helps also preserves the osteoligamentous complex.
Can I take opinion from Dr. Gadegune, sir? In a rural setup in India or in a satellite
So
city?
you want to compare two extremes, is it?
Yeah, so I would like to have his opinion because he also sees a lot of this complex trauma. So, Dr. Gadegune.
In our setup, it is very difficult to get even an arthroscopy also. So anyhow, our patient, they manage it. But this, to tell you very frankly, this needs to be addressed. But majority of our patient, they carry on for throughout life with the deformity and so many other things because the things are not amenable to them. So
given day one choice, what you would have done? Explode on lateral side?
I would have given a rim plate plus bracing for some time so that medial collateral ligament will heal. And in future, after this healing, the reconstruction of the anterior cruciate ligament by arthroscopy surgery.
Okay. Dr. Jetwa, you wanted to comment something?
Yeah, I think in this case, the valgus is not because of the full depression of the lateral condyle. It was the rim fracture. The valgus is because of the medial collateral ligament injury. And I wonder that even after this corrective osteotomy of the femur, there can be still some opening on the medial side. And I fully agree that we have to give all we can do for medial collateral ligament reconstruction. So basically, majority of the part of the lateral condyle was intact. So valgus is because of the MCL injury rather than anything else. That is what my opinion is.
There is a valgus also on the opposite side, no?
Yes, there is, but in this case.
So whether here whether there was an increased valgus or it was the same normal valgus?
No, because there was a finding in arthroscopy that there is a complete tear of medial collateral ligament. So now we know. Now in this case, even after all these things, we have to check clinically whether still there is an opening on medial side or not.
Okay. Thank you. Dr. Maheshwari, can you proceed with your final results?
I didn't know what I've done, how patient would actually tell me 3-6 months down the line what will happen. Maybe I'll have to go in and reconstruct ACL, MCL again or whatever. But I thought if I shift the line of weight bearing, at least I'm trying to act smart in the sense I'm offloading my medial collateral ligament, I'm offloading my lateral compartment, and all those things can probably work better. So that's what I did. And 6 months down the line, this patient was walking very confidently, quite well, good range of motion. This was only 6 months. This is about 4 years old now. I've not had a follow-up on him. And he was quite happy. And so I thought before one would believe it, if we can listen to this, what he says. So I'm asking him how many years? 2 years.
90% better feel हो रहा है, मस्त लग रहा है, सारा काम कर पा रहे हो, हाँ सभी काम है, चलने फिरने में कोई दिक्कत नहीं, भारी काम करने में कोई दिक्कत नहीं.
So for Dr. Katrak, he says I'm 90% fine, I can do everything, I can run, and he's very happy. And in Maharashtrian language, he's saying I must. Must means he's very good.
Fantastic.
Dr. Jitendra,
yeah.
Here, was there any instability of the medial collateral?
None.
After all these years?
None. He was.
So that means your recovery was because of the medial collateral, which got repaired automatically.
Absolutely. I agree with you. So this is my lesson I learned from this case. In any complex knee injury presenting late, examine the patient walking to see if there is any thirst. Thirst is a very important component. You may reconstruct whatever. If there is a thirst, it will kill your surgery. Ligament surgery, bony surgery, whatever surgery. You have to get the thirst out by doing a appropriate osteotomy or some very good correction. Now, correction of the thirst by realignment osteotomy is a very simple, if you can understand the work of it before any ligament surgery. That is more or less an accepted fact now in ligament surgery world. Often after osteotomy, and it is in the literature, ligament reconstruction may not be required. And a number of papers where you went for doing a PCL reconstruction, you just did a osteotomy to correct PCL and posterolateral corner, and patient said, I'm stable, I don't need any further surgery. And that's what happened in this patient. Everything sorted out itself because the alignment changed, MCL healed up by itself, ACL anything may not have happened, but as of now, he's stable. and he's not painful because lateral side is offloaded also. So I think osteotomy was a good idea that way to give him, at least in short term, a good result. I don't know what will happen in long term.
And it has become like a polio correction surgery.
Yeah.
Yeah.
It's
Thank
a
you.
biomechanics of the knee which you have kind of aligned to is suiting his problem.
Yeah.
If I
Thank
can
you.
ask you, Jitendra, if I can ask you, in the arthroscopy, did you find a tear of the MCL or only the weakness of the MCL?
So it was opening. You can
It
say
was opening, but there was no obvious tear.
you cannot really see an obvious tear. It just opens up widely.
So it is probably it is because the way it got stabilized. So probably it was detached on the medial side on the tibia, and then it got healed up.
No, there is always the MCL tear because lateral defect, like Dr. Jawar said.
Yeah. That is understood.
Tibial defect wasn't so much.
Yeah.
It was a medial collateral injury also.
Thank you very much, sir.
Okay.
May I ask? May I ask Dr. Rajiv Rai Chaudhary to share his screen? So he wants to move away from the ligaments and he wants to come to bone now. Dr. Rajiv Rai, can you please share your screen?
Is my screen seen?
Yeah. Screen seen, bone seen, no ligament seen.
Yeah, very straightforward. Grade 1 compound, 19-year-old chap, and there are no hidden things. The ankle is normal, the knee joint is normal. Those are the X's of the knee and the ankle which are normal. Now, plenty of management options, I'm sure. There will be someone who would like to nail it, someone who would like to plate it. Dr. Chanda, could we ask?
Yeah, we want an opinion poll. We will raise hand if you want to nail this.
Yeah.
So in short, we will get the answers.
I will nail it.
So majority have a feeling of nailing, but Tanna sir many times would recommend plate also for this.
No. Don't quote me wrong.
No,
Okay, sir.
He's converted to nailing.
No, don't quote me wrong. What I have said is people who have a problem doing the nailing of the proximal tibia, or they have a nailing of the suprapatellar approach, or even a highly higher up approach, because everybody is not very comfortable in nailing up proximal tibia. For them, even a plating is going to be equally good.
Good. Thank you, sir.
Right.
Thank you very much.
I want to make it very clear about it.
I have raised because of not interlocking nail, but for under nail.
Okay, so you would go for a flexible undersnail in
from below.
Young child.
Yes, from below.
So Rajiv sir, we are all ready with nailing procedure.
Right.
We are all tuned.
Now, actually, the patient presented to me 5 months after his injury, and I just put this X-ray.
1 minute, you have hidden this information to us.
No. I'm not going to hide.
5 months you haven't told us. Otherwise, we would be talking about differently.
No. This is a fresh.
Anyway, carry on. I'm just pulling your leg.
Okay. Now, that is the X-ray, the first X-ray, and the mother says it had taken 4 hours of surgical time before the patient came out. So the question is, what does this X-ray show? What has been done?
Can we have the proximal knee X-ray also, sir? Here?
I don't have it, but it is all right. I mean, there's no hidden agenda behind.
Okay.
The surgeon has tried to do a MIPO plating.
No, sir, it's open plating.
You see the staple?
It's open plating, sir.
This is open plating, sir.
Because it was 5 months old, he had to open reduce. Yeah.
No,
sir. This was
a fresh fracture.
By another surgeon.
No, this surgeon actually. Yes, sir. Please proceed. Raju sir, please proceed. Yeah.
This is the first surgeon. It is within 24 hours of surgery. This is the X-ray, immediate post-operative.
I'm sorry. So this is the day 1 or within few days of fracture.
That's right.
First day, sir. First day
operated upon.
Yeah.
First day operated.
So Rajiv, what are these multiple drill holes? I don't expect those zeros there.
Excellent.
On the medial side.
So plenty of holes. What else? I was not the surgeon.
But
There is-
we are
there is
just
a me-
analyzing an X-ray.
On the medial side, we can see some few staple marks
Staples,
on the
yes.
medial side.
Lower
Yes.
down. Yes.
Yes.
So something has been done on the
Sir,
medial.
he tried first medial plate. He could not do
Yes.
it, so he removed and do open plating lateral side.
Yeah, looks like that. Looks like that.
Or these holes of multiple polar interventions?
No, sir.
No.
He was trying to do a MIPO plating on medial
Medial
side.
side, yes.
Okay.
He could not do it properly, so he did open plating on lateral side hockey stick plate, hockey plate.
Shall we proceed a little bit?
Yes, sir. Please.
Yes, sir.
Is there anything wrong in this?
Yes, sir.
Is there anything wrong in this surgery?
No.
Yes, the plate is very much anterior, and the screws are going cortex to cortex in the distal fragment. So they might be having less hold, probably.
So they might be having bicortical purchase.
Yeah.
But they are through cortex.
They are
Very anterior
triangular.
plate.
The anterior part of the tibia is triangular.
Yeah, so he may be out.
Maybe.
Yeah, but let's see. So you can see some infrapatellar staples.
So he tried for an interlocking nail also first,
Absolutely. In a
and he
small
couldn't get the
setup,
reduction.
and he wanted to do an intramedullary nail. He put in some polar
Screws.
K wires or whatever, and he splintered the bone.
He must have, heard Dr. Tanna's lecture.
Yeah, but he forgot that if you don't know, you better do a plate. But let's see further. Multiple holes. Now, this is a full open incision that can be seen. And there is a drain put medially, if you see this very carefully.
Yeah.
Yes.
So again, the question, what did the surgeon attempt? He attempted a nailing.
He must have done first the MIPO plate on the platings, unicortical plating on medial side, and tried to do a nailing, but he could not negotiate the nail, and medial plate also has come out, and therefore he had removed that also, nail also, and then converted this to a lateral plating.
But he could have left the medial plate.
That must have been because of the manipulation of while doing nailing. That must have been loosened.
Because of splintering. Because of splintering, it has loosened. So he put the lateral plate anteriorly.
Yes.
So this is the situation.
Right. So
But
can we
whether
ask-
it got infected or it didn't get infected.
Yeah, let's see, sir.
4 hours infection is 100%.
ऐसा थोड़ा ही होता है यार.
Oh,
That's why the case is here.
So basically, he has exposed the lateral side. He has got the drain medially, so he has opened the medial side. With this situation, it seems he had no infection. But 2 months later, this is what happened.
All these are the structure. These all extra fracture fragment, they have become avascular.
Very good. So what should he have done at that stage? Because he has opened medially, the drain is there. He's opened laterally, the full incision. He has done the intramedullary side, so intra plus extramedullary, and that's the situation.
Infection or no infection?
I have yet not inherited, but
Okay.
it doesn't seem to be there is any infection that is noted in the notes. The wound healed.
Probably the bending of the plate is because of too much anterior plate. It can happen on the lateral plate, but in this particular case, it's so anterior that it is actually not supporting the whole bone.
Sir, working length is too much for this plate to be used. It is a bridging plate and open bridging plate. So these multiple holes are there, weak part in the fracture zone. So that's why it is bent.
Oh, I think that is not the reason.
Patient must have started walking also.
Yeah,
See,
one by one, please.
support.
One by one, please. Yeah. Yeah, Alok, you wanted to comment? Please, Alok,
So there
please
is no
comment.
medial support as well. So it has collapsed on the medial side, and the plate has bended.
So on day one, on day one, what would you have done additionally, Alok, to prevent this disaster? If this was your case?
I would have gone ahead and put a medial plate as well if I would have unable to put a nail.
Right.
Nail would have
Can
been
I ask-
ideal.
Okay. But while doing, if the fracture is comminution is happening and it is not behaving the way you would like, so what you would have done to address that part of nail? You would have changed the nail design?
So I would have tried to take in more anterior, more superiorly to get the bend and try to have a longer Herzog bend nail.
No Herzog, longer Herzog.
You will
Shorter Herzog.
Shorter
Herzog.
Shorter Herzog bend. Sorry.
Yeah. Can we take professors' opinion and expertise on this problem, which many times we face of a proximal tibial nailing procedure going not the way we would like? Professor, your opinion?
Yeah,
Professor.
It's a very good case because it highlights the importance of the starting point. And when you look at the lateral views, the starting scar or starting wound is at the level of the tuberosity. And it should actually be at the distal third of the patella, and then you go in very deep, which is the closest to the intramedullary cavity axis. And then your pressure to the posterior cortex is minimized. But with the approach level so distal, you cannot go around the corner, whatever Herzog bend you use. So it's really a problem of much too low starting point. And of course, this would be a nailable fracture. And the key is make sure you can really flex your knee on the operating table very well. We usually don't use a fracture table, we use a little frame. And then we go at the most proximal possible point, we go into the tibia. And other people use suprapatellar approach that's even more proximal. But the key is be as close to the longitudinal axis of your medullary cavity.
You haven't changed over to a suprapatellar approach?
No, I've tried a few times. I saw one with significant cartilage problem in the trochlea. So we don't use it frequently. What's about you?
No, I haven't done it much now. I think Dr. Gadigun has a massive experience of suprapatellar nailing.
I'm doing it routinely, and
now he is doing it almost every tibia, even the distal tibia, he does it suprapatellar approach. Am I right, Gadigune?
Yes, sir.
Okay. And
yes, the principle is the same. Be very steep, be as close as possible to the medullary cavity.
That's right.
This is suprapatellar.
Yeah. So while you take a proximal entry point, Professor, but while rimming when we rim this entry point, it slides down anteriorly. So any precautions while rimming? Do you have any special sleeves?
Yeah, we significantly flex the knee more than 90 degrees, and we go usually transligament. But our orientation is not the ligament, our orientation is the medullary cavity. So we try to plan that our vector is as steep as possible and as much in line with the medullary cavity.
And how often you use the polar screws for this?
Yes, here it looks quite distal, but the nail tends, of course, to move posterior, and we would insert it right from the beginning.
So can you
to the audience, if they are not aware, Dr. Kritik is the originator of the polar screw. He is the one who has introduced the polar screw in the world. Am I right, Dr. Kritik?
Yes, that's correct.
Yes. So, Professor Kritik, what do you feel is the best thing to use as a polar screw. Screws themselves, a Steinman pin or a drill bit initially. So what is your current choice and philosophy?
Yeah, if we leave it until final, beyond final fixation, we use the screw from the locking nailing set. If it's only temporary, I'll use a 3 millimeter K-bar or whatever, and then remove it once it has done the job.
Yeah, thank you, sir.
Now, if I can ask you, I think it is a very prevalent theme in India that in order to improve the fixation, we use the polar type of a screw by the side of the nail, particularly in the distal fragment, either in the distal femur or a distal tibia. How much importance you think it gives the stability, increased stability, by putting the polar type of a screw by the side of the nail?
Oh, we have done measurements on the tibia, distal tibia, and it increased stability by about 50%. So this is whenever you have a discrepancy between medullary cavity and implant diameter, polar screws can help to bridge the gap.
Okay.
Okay. Yeah. Raju sir, can you please proceed?
Yeah. So what the surgeon did here was he revised his fixation and put in an external fixator medially.
Good idea.
He is yet to come to you.
Yeah. So would you be happy with that?
Yes, I'll be very happy.
In the setup, he did the right thing. He didn't want to put another plate there.
I hope he has grafted this time.
Yeah.
He has not.
Oh.
He has not.
Still, the patient has not come to Rajiv.
No,
so
not
obviously
yet.
This has not worked.
Yes. So.
Okay. So 3 weeks later, the external fixator was removed. And another 4 weeks later, the patient started with 2 discharging sinuses.
The most interesting cases in the world are the ones which have really been ruined by the surgeon. They are the ones which are most interesting to operate.
Yes. Especially if you are not the original surgeon.
That's right.
So,
as I always give an example,
yeah,
I came back from some place as an examiner.
Yeah.
And I said they were very interesting cases. And one of my senior residents mentioned, that means, sir, they are not doing a good surgery. Otherwise, you won't get such interesting cases.
Yeah. Yeah, whatever God does, he does for the best.
Rajiv, the sinuses are from the pin tract or from the fracture?
There is a sinus on the medial side and a sinus from the lateral. So the medial one is the pin tract.
Now you know about it, because you only telling us a story which you know, which the patient tells you.
No, this is the time that the patient now, when he presented, he had these 2 sinuses.
The boss has arrived now. The boss has arrived.
Just arrived.
Yeah. And the clinical picture is also there, sir. Please proceed.
No, I don't. I'm sorry. I don't have a clinical picture.
How many months now, Dr. Rajiv? How many
About
months?
5 months. 5 months.
5 months gone. And we can't see the fracture clearly here. I suppose it has not healed.
Yeah, it has not healed.
Right.
It has not healed. So that's the situation. I think now the situation is very simple. Either
So
a
you
1
have
stage or a 2 stage. Debridement, removal of metalwork, and refixation.
Right. So any options? The fixation devices we have to, you would go ahead with.
Yeah, that's what I wanted to bring out. Anyone for a repeat internal fixation? I'm sure not.
So I would do a bone scan at this stage, because I think the biology has been buggered to quite some extent. And I may find that the big segment of bone around the fracture may be actually dead. And whatever you may try, it will refuse to heal. And if that happens and bone scan is not very good, I would hand this over to my Elizarov colleagues.
Excellent.
How with the bone scan, Jitendra
Yeah.
will be able to give you the real information. When you go down, you know that this is a dead bone, this is a live bone.
No. Bone scan can show a penic area around the fracture site. I mean, it's possible. It's not 100%, but it's possible that 1 inch around the fracture site is actually dead, and it is asking for excision of that segment. Otherwise, you fix a dead bone with whatever method, it sometimes refuses to heal up.
See, once it is infected, you will have to go down and open it up, and you will have to clean it out.
Yeah.
Once you have to clean it out, that is the time intraoperatively you will be able to know exactly what is dead and what is not dead.
Yeah.
But since I don't do Elizarov myself, and if I'm in doubt, I would actually not do it myself, and maybe I will.
No, that is different thing, Jitendra.
Yeah.
What I'm trying to say is whether the scan is going to be any additional value. Because once you go down, you're going to see what is dead, what is not dead, and what is the doubtful dead. You are going to remove all the doubtful dead.
And then what do I do if I have a gap of 2 inches there?
Yeah, then that's fine. I understand what you're saying.
That's why I'll have a Elizarov chap at the back of me.
Why you can put a fibula and put in a graft around fibula?
No, not in an infected situation, sir.
No. After the infection, not on the day one.
No, I would rather bring in a Elizarov chap who will do it in one stage. Everything.
So for you, all infected non-union is with Elizarov.
No, because our patients like one surgery, and Elizarov is one surgery which goes on for 6 months. The job is done, length is corrected, everything is done.
So one surgery with multiple stages.
One surgery, exactly, one surgery which every weekly or 10 days, the whole thing is going to be adjusted, shifted, dressings, lots of things that to be done.
Yeah.
But I think only benefit Jitendra, benefit Jitendra will be that you will be off the hook.
Yeah, that's also a fact.
Yeah. Professor Kretek wants to comment about this scenario, sir.
Yeah, very good. I think CT scan is a good idea. We would make it with dye, radiopack dye into the sinuses to follow the geometry of the infection. I agree with dead bone needs to be resected, and Elizarov is a very good option if the patient is okay with the external torture. No, with the external setup, and this is really very good. But also an internal option would be just debride it, resect the dead and infected bone, put in a spacer for a couple of weeks, come back, do a plating, minimal invasive plating onto the thick film of soft tissues onto the bone, and do segmental transport along the plate. It all depends on where the soft tissue defects are and how big the soft tissue defects are. Sometimes they need a free flap or something like that.
Okay, thank you, Professor.
Here we didn't have any major soft tissue problem.
Okay.
Okay.
So that way we were.
It's a very sound solution.
Yeah.
Very safe. Very.
I just want.
Sir,
Yeah, Gadegune sir, yes, you want to proceed, and then Dr. Shinde sir.
Raju sir.
Yes.
Yeah.
There is no soft tissue problem because already it has been handled thrice, medial side, lateral side. The potentially skin may be looking good, but there must be inside scarring and avascular tissues. Therefore, there is an internal soft tissue problem, though externally not seen, it is always there. Therefore, to go again through that soft tissue is another disaster will be there. So therefore, I agree with Jitendra sir that this patient should be subjected for Elizarov technique.
Shinde sir, you wanted to comment something?
Yes, I wanted to suggest the same thing. Whenever you are including such type of, at least at that time you should include one Elizarov specialist in your panel.
Okay.
So no one would go for an orthofix type of a fixator.
I just wanted to point
so that
out.
we will have his opinion also at the same time. No, just
agreed. One option of Elizarov and is always there. Dr. Jetwa, you wanted to say
yes,
something
I
else?
just wanted to point out that now plate is not bending. Earlier, plate was bending because I again think of that it was an anterior plate which has no good support. This plate is not anterior. This is a properly put plate. So probably with this plate, if you are very sure, you could have avoided medial external fixator by which you have invited infection probably.
Okay, Alok, you want to comment?
Yes, sir.
Yeah.
Sir, removing all the hardware and the necrotic bone, we can proceed with an antibiotic impregnated nail and a LRS.
Okay. So your choice would be antibiotic coated nail and a LRS system. Okay. So Rajiv, so you would just like to conclude this case so that we go with the
So basically, it was all a one-stage procedure. If you can see the arrow, and osteotomy, corticotomy has been done initially. There was some dead bone that has been dissected. This was not a very big amount.
Yes.
And very fortunately, about 5 months later, 4 months later, the fixator was removed. This has healed, but unfortunately, some amount of malunion has taken place here. The patient is happy, did not want any more orthopedic surgeons to touch him, so I left him as it is.
So patient did not want to have further orthopedic touching because he already had enough of Ilizarov problems?
He had enough of treatment, 1 year. Total amount of period was about a year. He said, now I'll think about it later.
Okay. Tanna sir, your comments on final result? Tanna sir, can we have Tanna sir's opinion? Okay.
In India, we are happy if the fracture is united. But I think here, with it so much of a deformity and everything, I would not be happy about it. Probably if you had, I would have treated it, take out the infection, remit out intramedullary, extramedullary, all dead bone to be removed, put in the antibiotic beads, hold it on for some time, go ahead and do the fibula grafting and do the grafting and do the plating and get the excellent alignment and everything.
So may I make a comment, Dr. Chandak?
Yeah, please.
I think that's why I don't do Ilizarov myself, because my Ilizarov colleagues are magicians. They can correct any deformity to the finest degree of alignment because they have all the tools with them. And number two is, this patient is not happy now, but I'm sure in 2-3 years, just talk to him politely, he will come back for deformity correction sooner than later.
Because it is not the problem of deformity, where are both the joints are here fired up.
At the moment, he's thankful that he's walking, but sooner or later he'll start asking for more.
I think by the time he gets the effect of the deformity on the joint, it will be about 10-15 years. Then it will be too late for that.
I think we must congratulate Dr. Rajiv Bhai for showing the final result, which is not a good result. It's really good thing that he has shown that what has happened at the end. And I again repeat that undernail, not 10 nail, undernail from below, underneath the medial cortex and underneath the lateral cortex, not in the center, can give away all these complex and problems.
So may I ask Professor Kretek, what is the status of Ender's nail in Germany? In India, many times, especially in Gujarat state and many parts of India, Ender's is still used.
Good question. We use flexible intramedullary pinning for pediatric fractures, but in the adult, it's completely gone.
Is that because of multiple reoperations or backing out of nail?
That's a good question. I actually don't know. It's not. There is no teaching. There is locking nails and locking plates have taken over the entire long bone fracture topic.
I fully agree.
Thank you. Dr. Kretek, yes. Dr. Kretek, I'll advise you, call Dr. Jawar Jetwa to teach all the Germans how to do the Ender's nailing. He's one of the experts of that.
No, sir, I tell you, he's very right. Professor said he's very right because teaching has gone out. But I have documented, published papers from Germany, from all over the world, from USA, from Brazil, from UK, who are doing endonailing in tibia. So give me a chance. All over the world, endonailing is going on. I have a published paper from the PubMed. So it is not the case. They are doing. But as he said very correctly, teaching has gone. So probably people are more learning of other methods than the endonailing.
And we all know that orthopedic surgery and surgery in general occurs in waves. And the fact that something disappeared at the moment does not necessarily mean it's bad or improper. And it might come back in another time. So this is all not static.
So thank you, Dr. Rajiv. With that good case you presented, the complexities of initial nailing procedure, then problems with the plate fixation, infection, and ultimate reconstruct with the lizard. May I now invite Professor Jethwa to present his case? Yeah, please unmute yourself, sir. So please unmute, sir. Please unmute yourself. You are muted.
Now I am muted. Now again, share the screen.
Yeah.
So again, it's the same type of a problematic case, but I'm just trying to show you that this was a case of a complicated intra-articular fracture of proximal tibia, wherein there was not only the problem of a intra-articular, extra-articular injury, but she was young with a road traffic accident, close injury, but had multiple fragment intra-articular, and there was an absent distal pulsation. It was a cold distal limb, and I was called in the middle of the night that you do something, and I was not prepared, so I sent her to higher center. And thereafter, at the higher center, they immediately put external fixator. For some reason, they could not do any limb salvage with a vascular intervention, but the limb had survived. Fracture was treated with external fixator. There was a distal good movement and sensations are also okay. And then she came back to me for the pin track infection, the external fixator was removed. So she came back to me and she said that do something because nothing has been done at that center. So I went for the CT angiography, found out what exactly is the problem with the artery. So it was ununited, 3 months old proximal tibia fracture with popliteal artery injury near trifurcation treated by external fixation, wherein there is a good distal perfusion, and the latest angiogram shows that there is a deficiency in the vascular region. So the point over here is the issues are that it's a 3 months old ununited fracture, knee stiffness in extension, there is no flexion possible, vascular structure displaced to inside of the fracture, technical challenges or challenge to protect vascular structure while fixing fracture, and patient was not ready to take any risk for vascular complication, particularly her husband. So they said, whatever you can do now, it is ununited, not infected, but it is with a vascular problem. So let me know the opinion, what can be done.
So opinion from Professor Kretek first. So vascular injury.
We should speak last. I suggest you should speak last.
Okay.
She is asking, wash me.
That's right.
She is asking, wash me, but don't make me wet. Okay. Yeah. And the knee is completely stiff.
Yes, knee is completely stiff, he told.
Not completely, but there is a jog of movement only, not very good knee. Yes.
So, and is it a non-union or is it united?
It's a 100% non-union. When you see under image intensifier, you can see all the fragments are moving.
Yeah.
And patient also is complaining like still everything is giving, you know, some sort of a movement, abnormal movement at that side.
So she cannot walk?
No, she cannot walk at all. She just cannot put a weight.
In the non-union?
Yes. Clinically also, as per the patients, and it is only 3 months, and we can see all this latest 3D CT scan and X-ray, we can't see any callus.
Before Professor says, because that will be the last word, can I
Yeah.
come in, Dr. Chandak?
Yeah, please, sir.
So one is that number 5 is not 100% acceptable. Whatever I may do, I cannot guarantee 100% that he will have no vascular problem later. That's number 1.
Very true, very true.
But
Sir.
I can have a safest possible approach. I would just fix this fracture in situ. I will put I presume the skin is okay. I'll put a lateral plate and maybe a small medial plate and fill that gap with a lot of bone graft. Not try to achieve any reduction, nothing, because the alignment seems to be quite reasonable. And that will take care of the vascular issue here.
Now, Professor Chandak, there are 2 steps in this particular case. So there is a 1 step where we have discussion. Again, there is a 2nd step also.
Dr. Chandak, may I suggest?
Yeah, please. Shinde sir, please go ahead.
I am suggesting why not to go for vascular graft first and external fixator. And once everything is established, then think for the fixation.
So you would like to go ahead with the vascular reconstruction, exploring those vessels, taking them out, reconstructing the fracture.
The reverse venous graft will work very nicely at this level.
Jetwa sir, what was the problem in this strategy you thought of?
No. Probably he is talking about vascular graft, not reconstruction of vascular system.
Reconstruction. Yeah.
So something in presence of vascular surgeon one has to do. And very rightly, Jitendra said that we cannot guarantee anything. And so now let me go a little ahead and
Jawar,
yes.
At the moment, the distal circulation, how good it is, because with the collaterals, because I think even if you do the surgery, if there is a compromise vascular wise, then the whole wound may not heal up.
Yes, as I told you, everything was good distal perfusion. Sensations good, distal movement good.
So the perfusion was good also when you were pulling on the leg?
That exactly I have not tried. To compress the vascular structure, but it seems like from the angiography that the trifurcation area is not like just kinked, it is completely damaged. So kinking might not help you to find out anything.
Sir, can we think of a gradual destruction by putting external fixator and pull the fragment a little bit down and maintain the circulation, watch on the circulation. If it doesn't get compromised, then once we achieve the length, we can go just midline anterior approach and fix up 2 plates and bone graft.
Yes, there is one of the good options, yes. So now the second slide is showing all this.
Please sir, Tanna sir, please.
Because even if this fracture heals up with the compromised vascularity, there is going to be claudication, his whole going to be walking distance and everything is going to be compromised. Even if it heals up and even if he doesn't have the deformity or anything.
That we can't say, Tanna sir. And patient has a choice to then go for a vascular bypass, whatever. That's his choice. And you can't say if she will have a claudication. It all depends on how the collateral circulation comes in.
Yeah.
At the moment, the family is not willing for vascular compromise because, impending amputation.
No. Now, we probably leave aside the patient's desire.
Yeah.
So what is the ideal treatment we would advise? First, we discuss that.
I would say fix it in situ. Do nothing to the bed supply. God has been kind, and we can definitely bridge this gap with some kind of a graft from else and stabilize this knee. Luckily, the articular surface is very good, and one may have to go second stage, mobilize the knee later on with the arthroscopy or whatever. But it is possible to get union in as it is positioned without touching the blood vessel. Go one plate laterally, one plate anteromedially, small one. Alignment is reasonable. I don't care about how the X-ray looks, but I think the alignment is going to be quite reasonable without touching anything, without elongating anything. That's my point.
Rajiv sir, you wanted to say something on this?
Yeah, I mean, in continuation with Dr. Jignesh Pandya, now in case we try to stretch out with an external fixator and the vascularity is compromised, at that stage, before it starts compromising, we can do an osteotomy of the proximal part of the distal fragment, bring it anteriorly and fix it and graft it. So there would be some shortening, but at least the vascularity has been preserved and hopefully it will heal.
Okay. Jetwa sir, can we proceed with the case?
Yes,
so that
yes.
the others can get a
I
chance?
think very good suggestions. And exactly that what I did with vascular surgeon standby. Dissection was done unhurriedly, very slow dissection, only on lateral side. And best possible reduction was achieved, whatever was, but I did a very thorough small dissection of the all fibrosis and all these things. And fixation was done. Void was not grafted due to possibility of vascular damage further, because it was that area where there was a vascular surgery. So if I put something blindly on that, it might cause some problem. So as faculty said that in situ, practically this was in situ, which I just fixed this particular plate. Fortunately, the lateral skin was good. It was not a problem even after putting this plate. And this is how the things went on. And it is a follow-up of 9 months. Now at 9 months, there was a malunited in varus. Knee flexion attitude was up to 90 degree. And then again, patients say that everything is fine. She has started walking with a stick and there was no vascular problem. And then she said that do something. So malunited in varus, good knee extension power because the quadriceps, everything was very well developed afterwards. And the skin was also not a big problem. I just took a long x-ray and tried to see how much is the malunion. And then now we have issues that again patient is asking them, can we do something more? So varus shortening, and the biggest problem at this time was hurting implant. She just showed me underneath the anterior angle of the plate, underneath the skin, that it is hurting a lot. And there is a compromised vascularity because we know that the main structure has not come back. It is all the peripheral circulation or the collateral circulation which is working on this. So now can we do something with this?
So you want to focus this question to somebody?
Anybody. I think you can just ask.
Yeah.
I would give it to my Elizarov colleague again.
Yes. Elizarov will work in this case.
So what is the aim? What aim?
Which means minimum cutting, percutaneous wires, and manipulate from outside gradually. That's what they do.
Now, there is a significant medial depression of the medial condyle of the tibia.
Yeah, so maybe a little bit of intervention may be required to lift up the
CT
condyle.
scan of the tibia plateau?
Yeah.
No.
Yes.
So, Professor, you wanted to comment the medial tibial?
I have a question. Wouldn't it be a good idea to have a CT scan of the geometry of the tibia plateau, especially of the medial condyle?
Yes, it's a good idea, but I could not do it. But this is one X-ray. I have got multiple other X-ray where X-ray itself shows significant depression on medial side. There is a depression, and patient also has on that side only at the anterior border pain. She feels it is a hurting implant, but it is true it was hurting implant as well as there was a depression on medial side. Both the things are there.
Okay. Can we proceed with the case?
Yes,
Yeah,
yes.
Yeah.
So what I did, I just said that I can do removal of implants only. I can do removal implants plus osteotomy and fixation, or leave it for now because enough is enough, just accept it. So what I did, I removed the implant. Intraoperatively, I just tried to check how much is the depression. And I found that there is a 36 degree of varus, I mean the depression on the medial side which is causing the varus overall. So at that point of time, I just removed everything and did a intra-articular medial condyle osteotomy and fix it with a point supported plate. And please look at this animation. I put this a wedge corticocancellous graft from the iliac crest of the size which I wanted to correct. And then I tried to get maximum possible elevation, wherein the left side it shows the preoperative X-ray, on the right middle side it is the postoperative, where the joint there was a deformity depression which was corrected like this, angulation was corrected. The breadth of the condyle was shorter, and that also was corrected by this osteotomy. And ultimately, I could get a fairly good alignment of the medial condyle with the same range of knee movement. And this is what has happened at the end of 14 months, that she is now happy with a very good flexion at the knee, full extension, and a reasonably good correction of the condyle. Thank you.
Dr. Tanna's opinion, sir?
No, it's very good, very good.
Yeah. So at the point, but fixation sufficiency for this fracture and osteotomy correction, is that a question?
Yes, that is what I just wanted to. We had a discussion that what I am going to talk about is point supported plate. This point supported plate is a new design which I'm going to talk about in our next whenever we get a chance. And that is something which is very important. Just you put a small 2-hole plate and it will fix up. But in this case, the fixation was more rigid because of the corticocancellous wedge. That wedge was fixing so hard that I had to really punch it. And the medial structure, well, sandwiching it so well that I had no problem in getting the stability. And ultimately went for a complete good union. And this is the final follow-up.
Thank you, sir. Thank you for a good case. Now may I invite Dr. Jignesh Pandya to present his case. Dr. Jignesh, please share your screen.
Yes, sir.
Yeah. Share screen from the bottom. Please share. Yeah. We're getting it now. Yeah, thank you. Thank you so much. Please proceed.
This is the case of infected non-union tibia with implant failure. I mean, when I received with the implant failure.
Yeah, please proceed with the X-rays.
So this is a 55-year-old male. I got these X-rays. 55-year-old male, road traffic accident, open grade 3 upper 4th tibia with vascular injury, and he was operated in emergency with vascular intervention and temporary external fixator, which was converted to Elizaro after a few days, once the limb survived. That was the history available. The Elizaro was kept in situ and continued for another 5-6 months time. There was no corticotomy was done, and the ring frame was maintained as it is for 6 months.
Dr. Shinde.
Yes, sir.
Yeah, please. Yeah. Dr. Shinde, your opinion on this Elizaro construct, you would have done something else?
There is only one ring in the proximal fragment.
Yes.
And with differential distraction, it could have been managed the reduction would have been better if the proper releaser of procedure has been followed.
Okay, perfect. Dr. Gadikone, you would like to suggest on this releaser of ring construct?
It should have been extended for temporary region in the supracondylar region femur so that it will breathe some time. But single this frame, it doesn't give a very rigid fixation or a stable fixation also. Let us see what has happened.
Please, Dr. Jignesh,
So,
please proceed.
after 6 months time, the surgeon was not ready to remove the frame, but patient got tired. He said, I don't want to keep the ring now. So the frame was removed, and after the mobility was there. So the surgeon gave 4 weeks interval after removal of the frame and operated with the plate and bone grafting. There was no infection at that time.
So
this was the situation.
This is immediately after the second surgery? Or
Yes, sir. This is removal of frame after 4 weeks of interval and then plating, bone grafting.
Okay. So comments on fixation?
Have you increased the slope?
Yeah, there is a deformity. Slope is increased.
Yeah, that's one. And I think without a medial support, this is bound to go into varus, according to me.
So you would have given double column support, medial as well as lateral.
One more small medial support because there's so much gap on the medial side. And in that cancellous area, those 4 top screws are not going to hold anything. It's a non-union. It is going to take time. It will go, tilt into varus. That's my guess.
Dr. Jetwa sir, you would have given a point plate here, medial side?
Yes, anywhere. Anywhere, if there is a gap, it's going to give you big trouble. So we need to do whatever we can do to remove that gap. But on medial side, I have put a small point supported plate as well. But sir said very rightly that there is an increased posterior slope of the tibia. That also is not good. But I don't know how much is the now vascular status. Everything is fine?
No, yes, sir. He leave a survived full movement of the distal toes and ankle, and there is no vascular compromise.
Okay.
Both
Any
the
other
pulsations
opinion?
are palpable. Pulsations are palpable.
Okay. Any other opinion on this?
This is not going to survive, Chandak sir, because there is a gap at the fracture side, there is a medial bone loss, as well as there is a slope of this upper fragment is also increased. Therefore, there is a completely unstable construct. Though there is a bone grafting, it will fail.
What additionally you would have done here?
I would have given a fibular strut on the medial side and small plate.
I think we can go for even some shortening, but we need to remove sclerosed part at the fracture site. That is not going to be very good because we need to remove all this, which is so much scleroed at the fracture site.
Dr. Rajiv, you would have done something to remove this sclerotic bone? Dr. Rajiv, sir? Are you there with us, unmuted? Dr. Rajiv, your comment on, yeah, please unmute yourself. Please unmute.
So already, Chandak sir,
Yeah.
from the picture.
Yeah. Before I come to your point, the increased slope actually is because of the patellar tendon pulling on the proximal fragment into extension.
Yeah, procuratum deformity.
And that is the cause of the increased slope. That's number one.
Okay.
So just a medial plate will not solve the problem.
Okay. So you would have given a bicolumn support?
Probably I would also put a small 1/3 tubular anteriorly as a buttress to prevent the 2 columns being pulled up by the quadriceps is a very strong tendon. Okay. So that's number one. Okay. Number two, there is a significant amount of gap between the 2 fragments.
No, he has already put in a bone graft, as he says.
Yes, sir. Bone grafting was done.
Because if the bone grafting is done, this gap, otherwise radiologically, is always going to be seen, though he would have really filled up the bone thing.
Yeah. Still, so I have not received the patient. Patient. I have not received the patient.
No, I'm talking about whosoever has done it.
Yes, sir. Yes, sir. He has done grafting.
If he has done a grafting, which is going to be not a just minor grafting, but really packed up this area, and he has done the adequate refreshing of the area, because I would not think in terms of really excising the sclerosed area. I'll scrape it out, I'll open up the medullary cavity, or I'll open up the cavity there, whatever proximally it is there and distally it is there, and then I'll proceed further.
Yeah. Can we have opinion from Professor Kritik?
And as Jawar mentioned, you don't need a very big plate here. You need a very small plate comparatively.
A small plate on the medial side. Thank you, sir. So, can we have opinion from Professor Kritik? Yeah. Your opinion, sir, for managing that slope of tibial condyle?
It depends does he have an extension gap at the moment?
No, sir. He could extend the leg.
So
completely.
Completely.
Yes, sir. He can completely extend the leg.
If he would make it straight according to the bone, he would overextend for 20 or 30 degrees. What I want to say is
he did not have hyperextension. I saw him after blade broken, but he did not have hyperextension.
Okay, so what he is suggesting is there was no hyperextension at this point of time.
Okay.
The extension was complete. Yeah.
No, but there is a varus deformity. There is a flexion deformity at the lower fragment. The whole two fragments are different. Probably he has tried to correct it at the lower fragment. Keeping the slope there, he has tried to correct it at the lower fragment.
Lower fragment. Yes, yes. Yeah. Please proceed, Jignesh sir.
Yes, sir.
Yeah.
And he came with this.
So
after 3
we
months,
all expect.
Yeah,
we all expected this.
Expected.
Yeah.
After 3 months, the patient was walking on the plate, and with the support of a stick, and he came walking with the plate, broken plate also to me. But he has a discharging sinus, and there was a mobility in the fracture with valgus varus strains.
The slope seems to have corrected by itself.
Yeah, because the distal fragment is displaced posteriorly.
Yes. So I think the standard opinion here would be all would be in unison with only one methodology. Open reduction, internal fixation, correction, and bicolumn fixation.
Now it is complex by the infection.
Yes, sir. There is a discharging sinus.
Yeah.
So
Anteromedially, there was a discharging sinus and continuous draining was there. If you put a dressing today, tomorrow it will get totally soaked. It was like that.
So full stop now. It is now correction of the infection. Do the cement beads or whatever you want to do it. Get the specific entity 2, 3, 4, 6 weeks, 8 weeks.
Yes.
Now you go down and correct it. So now we talk about after the infection how to go about.
Yes.
Or if anybody wants to do all together on this one stage, I doubt very much. I don't know.
Is it possible
Sir, in metaphyseal lesion, one stage is not good because it will be difficult. Metaphyseal difficult to get an infection, get rid of in metaphyseal lesion.
What is
in the Germany, they do the total knee at one stage. So फिर उधर किधर सवाल है यार?
Dr. Jignesh, how mobile is this fracture now clinically?
Sir, patient could walk with the stick.
It means it is fibrous union.
It was fibrous union because he was walking, but
I'll just drop this.
with varus deformity.
No, I have not heard Salaben coming.
It seems to be not much of varus.
So it is a strong
when he weight bears, it goes further varus.
Okay.
So
it was a mobile fragment. It was mobile. But
So
he was not much in pain. He was walking. He came walking with the stick in my clinic with broken plate. I wasn't expecting plate to be broken when I took the X-ray.
So I would actually, I don't know how bad the infection is, but
Sir,
I would.
if you put a dressing, sir, if you put a dressing today, tomorrow it is totally soaked.
So I would consider doing it in one stage with the caveat that I may do it in 2 stages also. I'll put an anterior to posterior 2 interfragmentary compression screws and then support it with a medial external fixator, just a fixator, and bone graft this area.
Okay. Any other opinion or otherwise we proceed? So that. If all are agreeing that it needs to be, the infection needs to be cleared and then adequate fixation.
So it is either one stage or two stage.
Yeah. And please proceed, Jignesh.
So what we did debridement, removed the implant. And when we removed a lot of granulation tissue was there, it was almost bowel was full. I did not have a bowel, picture of the bowel full with the all material. And there was no frank pus actually. It was all serous. So we cleaned it, thoroughly washed. And we put, whatever the gap was there, we put totally block of the cement, vancomycin with gentamicin, and cement beads on both the sides. And it was, after putting a block, totally filling the gap on the proximal and distal fragment, it was quite stable on table. And patient was, after 15 days, once sutures are out, patient was able to walk with the walker with partial support on the leg.
So all agree with this methodology, or we would have provided a fixation?
Patient did not want any type of external fixture, sir. So we planned for putting a cast or some brace like that, because he was not ready for any type of external fixator.
Okay. Please proceed.
So we avoided fixator because he said, I don't want anything external.
Yeah. Please proceed what you did.
So we waited for 8 weeks, totally silent. Everything was, there is no disturbing sinus now. Totally healed skin.
Can I ask Professor Catterick, does he have those kind of demanding patients in January in Germany? That we don't want this, we want this only, and
oh yeah. Teaching the patient and educating the patient and bringing him down to earth is a big part of the treatment.
Right.
And the expectations, grounds the expectations.
Yeah, Jignesh, please proceed.
So and it was I mean reasonably stable after putting a cement and everything. So I thought let us continue with some slab or brace, something like that, and let us wait what happens. So because he already had a reserve for 6 months and he was tired of it, so he did not want any external fixator. So we kept it like that. After 8 weeks we went in, and I did this. We did double plating, bone grafting, and this is 3 months follow-up. You can see totally wound healed, quite good range of movement.
So you provided infection control, good stability.
Good stability.
Yeah. And then that has given you a good result.
And cement beads have worked very nicely, and it has corrected the, totally controlled the local infection. And I had we could put 2 plates. And with 2 plates, there is a very good stable situation created, no valgus deformity, and we could not correct the posterior part of the angulation because I did not have any heart to go posteriorly because already vessel was repaired there. So I did not go in the midline posteriorly and to correct the posterior angulation of the distal fragment a little bit. I accepted that.
Yeah. Thank you, Jignesh. A nice case and a good ultimate.
This is 6 months follow-up.
Yeah.
This is 6 months follow-up. It is totally healed. And you can even almost good range of movement also in the knee joint.
I was just
Gadegunde sir, can you share your screen, sir, by the time we discuss?
I was just thinking that we could have avoided lateral plate. Only medial plate would have worked because patient has already good stability.
So you would have given only one side construct,
medial
even
side,
in a
yes,
non-union.
only medial side.
And non-union. Okay.
Because it was a good stability. It was walking.
Sir, in a resistant non-union infected case, I didn't want to take chance.
Yes, yes, that is true. That is true.
Any experience of recrudescence of infection in all this infected scenario? So not immediately, but after some time.
So this can happen. So I am giving a follow-up. He used to come, but because of the lockdown, he did not come. I said him, you see me every 6 months.
It is a common finding. It is a common finding.
Common finding, sir.
These are very, very much true because if you see the last X-ray, there are so many, black sort of a cystic areas.
Yes, sir.
We do not know there can be some harboring.
This can be infective focus or not.
Yes.
So I asked him to see me every 6 months.
And even as she is a vascular injured case,
yes,
there
sir.
is no chances of infection.
Yeah.
Yes, sir. Yes, sir. Very right, sir.
Yeah. Jignesh, please stop your sharing.
Yes,
Dr. Gadegunde is sharing his screen so that we finish up the last 2 cases as well. So we'll have to welcome Gadegunde sir for your presentation.
So this is a, am I audible and screen?
Yeah. Both is seen, audible as well as
this is
screen.
just a simple case. You get routinely a 45-year-old male after motor vehicular accident sustained a closed upper 1/3 tibial shaft fracture, oblique spiral fracture, no comorbidities, nailing or plating, there is no question. Majority will say there is nailing. Whether to use an infrapatellar or suprapatellar approach, debate will continue. There is no problem. You can choose any approach as you wish. Operated in other facility with an interlock nail by an infrapatellar approach with a regular nail. X-ray revealed coronal anterior split. Posterior cortex was shattered, converting into a complex fracture pattern extending into the metaphysis. You can see here it has gone. There is a coronal split and the screws are in the coronal split. So propagation during nailing procedure, forceful negotiation of nail, mismatch, Herzog bend, that may be another cause, stable fracture converted into an unstable fracture, and the entry point may be responsible for the propagation of the fracture. As Kretek sir said, it should be higher up. Here it is a lower up. Herzog bend hitting to the posterior cortex, and there is a coronal split because of the forceful negotiation. So procession of fracture, coronal split, loosening of the screw, pain on motion and potential infection. Hence, index surgeon removed the screws and applied plaster for 1 month. That is his theory. I don't know why it has done it like this. And after 3 months post-operatively, patient complained of pain, inability to bear weight after removal of POP and presented to me with this picture. Now, this is the picture. It is available with us. What we can do here, what to do. So this is for open for discussion.
Dr. Jetwa sir, what would you like to put here?
I think now it's very clear. I suppose that there must be too much stiffness of the knee as well.
Yeah.
But whatever this knee stiffness is there, we should remove this nail now, put a good medial plate with a lot of bone graft, and get the alignment seems to be good. But now we have to see that we go and put a plate rather than depend on any other nail.
Professor Kretek, would you like to still manage this, continue with intramedullary nail options with nailing procedure, or you would like to convert something else? Yeah. Would you like to manage this nail with a modified technique of nailing procedure?
Question to me?
Yeah, yes. Sir.
I think starting point is too low
Very
and
low.
too far medial. I would go up and more to the lateral side to hit the vector of the cavity, and would place a posterior and lateral polar screw, and maybe would consider reducing circular schwa.
Okay, perfect. So, Gadigonda sir, can you just please proceed?
So treatment options: removal of the nail, followed by locking plate, exchange multi-lock nail, or retain the nail and augment with the plate. So these are the consensus. So addition of bone graft if needed, and that is the surgeon choice. My plan was to retain the nail, reduction of a long oblique fracture with a percutaneous clamp, and augmentation with the plate. So what I did, immediate post-op, augmentation with simple plate. So just I retained the nail inside and do with this a medial plate, and there is a perfect restoration of anatomy. All fragments, they are in good place, and this was the post-operative X-ray. Is there any
comments? Any comments
about this fixation?
There was no infection.
There was no infection.
Yeah, Professor Kretek wants to comment.
The nail looks deeper inserted as it was before. Is this a wrong impression?
Dr. Gadigone, is the nail you have sunk further, or it is
No,
it is just a
it was just reduction, put that nail inside it has sunken.
so
I have
while
not
reducing you yourself made it go deep, or it happened automatically?
It happened automatically.
Because it's not removed distal locking anyway.
Yes, I have not removed distal locking. I reduced the fracture and then I did the plating, and that because of this, it was too much sunk inside before in the post-operative X-ray, and because of that, there is a migration and everything was there, overlapping of the fracture because of the fracture propagation.
Okay.
So actually, the entry point was in the initial phase it was very wrong.
I think that keeping the nail will prevent you passing bicortical screws. And once you remove the nail, you can pass a good bicortical screw. But at the same time, not passing bicortical screw is again supported by the nail inside.
Yeah. So that a combination of method, a surface implant as well as intramedullary, gave him a good result. Thank you very much, Gadigone sir. And to have
the complete union and full function, patient returned after 4 years post-op seeking advice for implant removal. So plate and nail construct sometime, it's a minimal invasive surgery without going into the exchange nail. I did just a very small surgery and fracture is healed. Thank you.
One question can I ask, Dr. Gadigone?
Yes.
Yeah, please.
You see, the fact that the split happened was because nail was causing that, the split.
Yes.
Not the presence of the nail. Once you use a clamp, how do you manage to reduce that gap? Because the gap has been created by the nail itself.
After restoration of the length and clamping and reduction of the fracture, everything fall into the place after doing a plating. So anteriorly, it was a loose piece because of it is abating. The anterior part of the nail was abating. As soon as the fracture is reduced, and now you can see that the anteriorly placed nail has gone into the substance of the medulla, and therefore there is a change in the position of the nail also.
The nail has moved inside.
Yes.
Because the interlocking screws have been removed. So now nail has a play. It can go down.
Right. So thank you, Gadigone sir. Thank you very much. Alok, quickly share your screen. Though we have extended beyond our time limits, but the last batsman batting is there. So Alok, please share your screen quickly and proceed with your presentation.
Now Alok is the last one.
Yeah,
Yes.
Alok is the last, and after that, Tanna sir.
No, I think now you and me were the stepneys.
Yes, sir.
So even I was one of the stepneys.
Alok, please proceed.
Yes,
Please
sir.
proceed.
So,
and I'm so excited, Professor Kretek, Professor Tanna, both are still available with the webinar.
sir, this was a case of a 32-year-old male.
Share your screen. Case for webinar, click on that.
Green button.
Yes, sir.
Just open your presentation. Is there on the desktop?
It is there in the center of the desktop, Alok. Just click on that.
Dr. Tanna, we don't need Dhoni anymore. We have made it.
But I think you did it at the beginning of the session.
Sir.
You did
I'm
it.
doing it again.
Yeah. Just do it. No problem. Don't worry. Take your own time and you will be able to do it. Just go ahead.
See how much encouraging is Rajendra. See?
Yeah.
Don't worry.
Yeah. He'll be able to do it. It is much less complex than the complex non-union.
He has to keep the spirit of the team.
Yeah, that's right.
Yeah. Thank you. All lessons I will have to learn.
Try
from
again.
Tanna.
Try again.
You did it. Yeah.
No, now again we are seeing.
Share again, Alok.
Yes, sir.
Yeah.
Sir,
Yeah, that's fine.
Yeah.
Just go on the presentation mode, Alok. You will be doing it.
So is it okay now?
We are able to see screen. Yeah, perfect.
So 32-year-old male was operated in other state, had come in with a pouring pus and a exposed implant on the medial side. And he was operated around 5 to 6 months back.
What do you mean by pouring pus?
I mean, sir, it was a daily soakage. I mean, there was nothing like today's dressing. It will, after 4 hours, it will again come with frank pus.
अरे कुछ फर्क पड़ता है कि even if it came after 3 days?
Nothing, sir.
Pus is a pus, is a pus.
Yeah, yes.
There is
So-
a bacteria infection.
Yeah.
So if somebody else's case, it is pouring pus, and
Yeah.
our own case, it
Our
is,
is
it is
just a drop.
yes, it's a pus discharge.
Yeah, yes, sir. It was a,
Yeah, please, hello, please
Yeah.
proceed. So you have two problems in
Yes, sir.
non-union infection.
yeah, both.
And the first correction is the infection, then is the non-union.
So, sir-
Non-union will need 2 plating and a bone grafting.
Yes,
But he is going to present something else. Hello.
Oh, is it? Alizarao?
Yeah.
No, sir, not Elizaro, sir.
Bolo, proceed.
So the plan was to eradicate the infection and achieve stable fixation. So
Yeah, exactly.
the treatment options, you can plan for a 2-stage surgery or a 1-stage surgery. And you can do an implant removal, do X-fix, antibiotic beads, and then second stage, you can do a plating and all. So any opinion of the senior faculty, how to proceed, beside what Tanna sir has spoken? Any other different opinions?
So if you would like to, if you would all would like to have Professor Kretek's opinion on infection scenario. So what stages you plan? 1 stage, 2 stage, or 3 stage, Professor?
Usually 2-stage. Implant removal, debridement, antibiotic spacer. And usually we do not add on the tibia. In most cases, we do not add an external fixator because usually a brace together with the fibula gives so much intrinsic stability that we can avoid additional external fixation.
Thank you, Professor. Alok, please proceed.
Yes, sir. So we planned for a single stage. We remove the implant, send the sample for culture sensitivity. We gave a wound wash. We use reamers to ream all the whole medullary canal and pass in antibiotic saline through it. And we put in an antibiotic cemented nail with the LRS external fixator. That was the post-operative X-ray initial. And
So is this your routine protocol even for a mid-shaft tibia, or because
Yes,
it was
sir.
metaphyseal, you?
If it is an infective non-union, we proceed with the antibiotic impregnated nail, not a LRS always. So we use an IV antibiotics for 2 weeks and then oral for another 4 weeks. And this is the post-op protocol which we followed.
Why did you use LRS?
Sir, to prevent any collapse on the medial side.
No, because probably on the table you found that
Yeah.
this nail is not really giving stability.
So maybe I was a bit apprehensive that it may collapse later on.
No, because this one nail here,
Yeah.
it is not really likely to give you stability.
Yes, sir.
And I don't know whether you locked it. Doesn't look
No,
like.
sir. So no locking, sir.
So this will not give you stability. So it is much better you put in the X-fix.
Yes, sir.
Okay.
Then we proceed with the follow-up. And the wound healed on the medial side by secondary intention. This is what was at 4 months. And this is at 5 months after removal of the LRS. And this is at 7 months. Now the patient was lost to follow-up. He turned up at 3 years.
Now abhi nikalo nail. Kaisa nikalega?
So now the wound is healed. And we have even removed the nail, but I don't have the X-ray of the nail removal. So I'll definitely put in next time. And this is at 4 years. Yeah.
That came out easily, or you had to drill out
No,
all?
sir. Sir, we had to, we have devised reamers which we put in over the nail and then we remove it over it. That is a antibiotic nail removal device.
Okay, so you over-rim on this and then remove it.
Yeah, yes.
Okay.
So
So
this
that
is
must
the-
be 11 mm at least.
Yes,
Yes, sir, you wanted to comment? Yes.
Yes,
Unmute yourself.
in this particular case, you can even push the nail out by passing an ender nail from below, and that will push the nail out if there is a difficulty in removal of the nail.
But if osteo-integration is there, it would not come easily, sir.
No, it would come, but if there is a one more method where you want to push it from below, you can pass a under nail 4 mm, and then it will touch the lower end of the nail, and then once you give 2-3 hammer, it will push up further.
Jawar, I think it will push up probably an ordinary nail which is broken, but this is a cemented nail.
Yes, but that also, once you do everything proximal, it is not simply that you do only one method. Proximal, you try to loosen it up, and thereafter, little bit more push can be done with this.
Sir, it is not always you are lucky. Sometimes osteointegration type of phenomena occurs, and even it is difficult by any method you try. I have tried in the last week and failed number of times. So this is not the egg. Actually, he is a lucky man to get it out, and we should thank Alok for his victory.
So that was the range of movement the patient had?
Yeah, perfectly healed.
Yes.
Absolutely. Yeah.
Sir.
Thank you, Alok.
Yeah,
Thanks for
thank
that
you, sir.
wonderful
Thank you.
case.
Very good.
And with this wonderful case presentations and an excellent and awesome presentation from Professor Kretek, and a good lecture to begin with from Ashok Gavaskar, and good cases and good interaction with faculty. This is time to wind up this webinar. We have exceeded from the time, and I'm so happy that Professor sat throughout the webinar and put his valuable comment, and it was really an honor for all of us that you were here, and all of us really enjoyed your webinar, your presentation, and as Dr. Tanna said, possibly this was an eye-opener for all of us for reconstructive surgeries. Thank you very much, sir. Any comment? Tanna sir?
Yeah, I think he inspired us also, and he made us very, very depressed. How the hell we are going to do this sort of a thing?
No, he was looking for Indian jugaads.
Ask a parting question to Professor. Hello.
Yes, sir.
Yes, he's listening.
So my question is, Professor, that sometimes these patients are on the borderline of 50 to 60 to 65, where knee replacement is hanging outside your door, and there very often I almost always do arthroscopy as a first step to reconstructive surgery of the knee, and very often I'm surprised the knee, which looked quite reasonable on the X-ray and MRI or whatever, and when you look inside, you find this cartilage is not there, and that becomes a turning point to my going away from reconstructive surgery, particularly if the patient is 55, 60. What is your comment on that?
Yeah, it's as we have seen in the discussions before, orthopedic surgery is always decision making with many, many variables, and most important, the patient is increasingly expressing his opinion. I think it's, as we saw in the first lecture, it's always a very individual. We have a couple of general rules: alignment, stability, congruency. But at the end of the day, it is a very, very individual recommendation we can give. And the older the patients, the more the expectations are changing.
I have a same question that regarding the CT arthrography.
Yes.
Can it give the same sort of information as we do with arthroscopy?
Yeah, I think it's limited invasivity, and it gives fantastic images. And we as orthopedic surgeons have now viewers on our desk, and we can go really into detail and turn it around and play with it to get improved informations compared to what we had 20 years ago. So I think this 3D data is an absolutely amazing push forward for our understanding and for our planning complex things.
Thank you, Professor. Ashok, do we have any questions on the WhatsApp if you have given the number? Ashok?
Can I ask one more question?
Yeah,
Dr. Chandra?
yeah, please, sir. Yeah, please.
So my question is, often making an assessment with the implants in situ is very tough. You even on CT scans, it is so difficult to make out what is where, and you're lost with the all 3-dimension CTs, whatever, you cannot really make out which fragment is where. What is the suggestion from Professor?
Yeah, I think if the implants are over proportionally disturbing your interpretation and your analysis, once surgical step in between removing the implants and then to proper imaging is a valid one.
Right. Good. Thank you.
So, Ashok, do we have questions for the panelist?
So he must be busy somewhere else.
I'm here, sir.
No, he is here. He is here. He's just seeing his chat box. And if all the panelists permit me, can I just post one patient of extracutaneous plate fixation in an infected scenario?
So that would be great, sir. Please.
So Tanasa, with your permission and with Professor's permission, I'll just present one.
You don't need the permission. You are the boss.
Yeah, I'll just share this.
We need your permission.
So this was a patient who had nailing after
we can't see anything. We can't see anything, Rajendra.
Yeah, you are not able to see?
Now.
Okay, I'll just again share, sir. Yeah, you are able to see now, sir?
Yes.
Yeah. So this patient had interdoc nailing done for a grade 3 compound fracture tibia. And as the patient's relative gave me this X-ray after 1.5 years of his initial treatment protocols. So this was the extent of injury. And as we can see, there was a large flap in his compound fracture. And this was the incision of nailing done. And he had subsequent debridement. And in the whole scene, the tibia was exposed, the nail was seen, and was debridement done in multiple sittings at the initial center of his orthopedic management. And this was the X-rays retrieved by the patient's relative. At the same center, because he had infected a scenario, the surgeon had done external fixation, excised all that initial immediate bone, but the excision of the bone was not complete because the whole segment, as we can see here, was necrotic. From almost proximal end to the middle end of the tibia, that was all necrotic. So initial excision was done, and then they had done with a flap cover. So for managing that patient, initially we just put a small X6 pin on the lateral side, excise the further segment. This was the amount of segment which was excised. This is an antibiotic cement spacer, and 2 or 3 reinforcement K-wires were there to initially put into the tibia so that gives stability. As Professor Kritek said, fibula is one thing, but since here large segment was there, I had to put in a large antibiotic cement spacer. And then we managed him with extracutaneous plate or a supracutaneous plate in view of a very poor skin condition. The skin tunneling for the MIPO plate was not possible because the skin was stuck up and had a previous badly infected scenario. A large segment was excised. A complete large segment excision was done and a soft tissue. This is the what I call as a beauty of extracutaneous plate. All the multiple screw tracts, since it is firmly holding, usually the pin tract is quite less found, and that was reconstructed with a extracutaneous plate and reamer irrigator aspirate bone graft are obtained. These are the follow-up X-rays of graft consolidating. Though this appeared more denser, but on clinical examination inside the theater, there was punctate bleeding. The paprika sign was positive here, so I did not do. Phase 2 problems of proximal truncated bone junction, and at the end of around 1 year, this patient healed completely. So the point of presenting this was an extracutaneous plate in a scenario where it is quite difficult to put in a inside plate, or even a nail because the condition is not favorable. This is one valuable option which I find, and I'm quite excited about it. The last X-ray I would show, this has consolidated well. Patient is completely weight bearing, and one good thing about it is, in case when you want to remove it, you just dynamize it further, make it still more flexible so that the consolidation proceeds fast. I would just invite opinions on that fixation. Extracutaneous to me appears a possible replacement towards X-fix, providing two main advantages: that the pin tracks usually are quite dry. Even at the end of 1 year, he's absolutely fine. And the fixation is in multiplane. So, and the patient can walk on his own trousers without any additional problem while walking and sleeping. Any opinions on that?
This bone formation which has occurred is not enough for him to walk about. He's going to crack down.
Yeah, and therefore,
however, you'll have to manage it for few years with the support and expected a stress fracture, and then probably it may heal up, if at all. Yeah. So probably I feel addition of the fibula along with the bone graft could have been a better option.
Absolutely agreed, sir. And that is what my concern is. What I'm trying and exploring the possibility of dynamizing this construct, removing half of the screws, and I'm observing, and possibly at the end of another 3 to 4 months, if I find this regenerate. Right now, he is walking without any support. He is full weight bearing, but I don't know what would happen. The one opportunity
at the moment he is walking on the X-fix, no, or whatever your plate which you put it outside.
So what I did one is, I just loosened the screw in one of these patients and tried whether patient can weight bear, and they can weight bear on this completely. But as you said, I am quite afraid about a long segment reconstruction and a stress arising in that area.
So now Gadi Gune, now it has become an Indian jugaad.
Yes.
No, I think we have the same experience.
Further science will solve the problem.
Sorry?
Further progress in the science will solve the problem.
We have the same experience. It is fantastically fixing it. There is no pin track infection. We have done in 3 cases. We have just changed the screw design so that the threads are not outside the skin. There is a long area where the threads are not there. It's a plain shaft. But in Korea, the number of publications, number of photographs you can see that they are using this supracutaneous plate so frequently.
Now you mentioned Jawar.
Yes.
Sorry.
Sir, what
you mentioned Jawar. Sorry.
Okay, sir.
Please carry on. Please, your privilege.
Thank you, sir. Sir, sir, can you make this all whole combine and make a long slot in the plate, which can transport the bone from distal fragment to proximal? Just add a knuckle, and you can just transport putting one screw, and that screw will transport the fragment completely.
Good idea. It can be, yes.
And it will work like a Elizaro.
I think Dr. Kulkarni has done this.
Yeah, slotted plate he has designed.
He is doing that long slotted plate, on which he puts the screw, and he does this. So he does the segment transportation, so it goes into that track.
So that was intracutaneous. This is supracutaneous.
Yeah, this is supracutaneous.
Why cannot you accomplish the same thing with the LRS?
Yeah, you can put separate LRS entirely, but then it will increase the bulk of the external fixator.
Now the issue is not the external plate, which we all know it has worked. And now, as I want to say, Jawar mentioned about the screw inside. Now he has put the screws outside. Still he had no problem. Jawar had no problem. So we make our decisions on 1 or 2 cases.
Yes.
Yes, absolutely, sir. And therefore presenting this case to get your critical comments and future options so that we can explore them.
No, I think the only issue is the time to consolidation is going to be huge here. Because even if the bone formation has occurred, that bone which has to hypertrophy to become a tibia is going to be a long time.
Yeah.
This is my only concern.
Yeah. I think Professor Kretek wants to comment on this
issue. We have seen many applications. I think it started initially in Zespol in Poland. It's the first applications where we had the free access to normal external fixators. then it became sometimes quiet around it. But this is a spectacular case, and I'm very confident this is a good working compromise between bulky external LRS type and completely internal fixations, some internal external fixation. And I agree with Dr. Tanna. Distally, there is some pre-fracture indentation, and
Yes.
if the patient might jump off a wall or something, this might be the initial course of a fracture line. And but you could easily combine this with a small size transport external fixator, just for the task of making a segmental transport along the plate, which is also very valid and not a bulky thing to do. And you can even do a 2-fragment external transport, proximal and distal, to move towards each other, so we have half the transport time. So I like the idea of this external plate, and I think there will be interesting future applications of it. That's not yet the end of the story.
No, but that will be the end of the story of the Alizarao people. Now, Alizarao specialists, what will they do now?
Yes, the limitation of the plate is that you are very limited in angular corrections during the course. And with classical Alizarov, you have all these amazing options, and including the foot, etc.
Yes.
So it's like a music instrument. Many keys.
That's right.
Many
instruments make good music.
Yes. Thank you very much, Professor, on that count. And Ashok, thank you very much for allowing us to extend this webinar. Almost it went for 3 hours. Any final comments if faculty would like to make?
I have one query. Dr. Chanda,
yes, sir.
Can we have an option of Elizara with bone transport in this case, which you have applied external plate?
Yes, sir. It can be there. Basically with the plate, but that can work for a small length of time.
No. We have transported 15 centimeter, 14 centimeter can be transported. Total shaft has gone out, and we did with the small proximal and distal fragment.
The one constant problem we used to face with Elizaro patient is they want that external attachment to come out. Here with the plate, it is more patient friendly. That is what I am finding. I'm not saying that this is absolutely comfortable, but they are able to join back their offices. They are working. Even some of these patients are driving their vehicles. So I am currently happy. I don't know what could happen in the future and the further expansion of it. So currently,
I have one doubt, as the diameter of the screws are more than the Elizara wires, there may be chances of infection more in your system.
Possible.
Also the other way around. Alizar wires can move a little. The screws are fixed, so the chances of infection may be less. It is all these are all the guesswork which we do it.
No, sir.
It is a good system. Probably it's going to last.
Yeah. So in all last 30 patients, this was one constant finding that there is no pin tract at what our boys call them as screw tract infection. So there is possibly none so far. They may happen. One good thing about this is, see, even in a parchment skin which is stuck to bone, these screws provide an absolutely firm construct, and therefore possibly there is no infection. In Elizaro, some of the wires may need retensioning. So the options are open. I have also experienced previous Elizaros, but one constant thing, these patients have never asked to remove it. If I ask them to hold on for another 3 months, they happily have accepted it. But possibly that could be my bias towards the system.
And sir, now it is more than 8.
Yes, sir. Thank you so much. And
just one update that a good amount of 3D printing is going on in India. Very good 3D printing is going on in Mumbai. Few of the cases have also been done in Ahmedabad. And people have also prepared us the fractured cases with the 3D printing, but yet the corrective jig for osteotomy is still not made in India. But good progress is going on.
Thank
so
you very much, sir.
you are mechanically oriented. You are the ideal person. Do it, no?
Yes,
And
yes,
help
yes,
all of us.
It's going on. It's going on, sir. Yes,
Ah.
yes, yes,
Yes, sir. And that's a wonderful, on that cheerful note, that all the faculties are still on the webinar. Professor sticking to the end of the webinar, and Tanna sir giving us guidance throughout. Tanna sir, we have really encouraged by your presence till the end. Thank you very much, sir.
No, I think it was very enjoyable. Thank you very much.
Yeah, thank you very much. Ashok, it's a time you would like to have concluding remarks, Ashok? Or Gadegone sir, you wanted to?
Yeah, go ahead, sir.
रहने के बाद सभी बढ़िया होता है. Selection of faculty is excellent, and we
lost you. Yeah. Thank you very much, sir. Thank you for that comment. Ashok, you wanted to say something?
और शिंदे सर भी आखिरी तक बचे हुए आज.
Yeah, he has. So organizers remaining till the end is a
topic is
great
interesting.
reward.
Yeah. Because of topic and because of faculties.
Thank you very much, sir.
Thank you. Bye-bye.
Thank you, Professor. Thank you very much. Yeah,
yes, sir.
thank you very much.
Everybody.
Yeah, thank you very much.
Fantastic. Great moderation.
Thank you, sir.
Thank you so much, sir.